Sai Ram, invoking the blessings of the Almighty and our Guru, Sadguru Shri Madhusudan Sai, to all the delegates, healthcare professionals, experts, volunteers, administrators, who've come from far away from 9 states to this beautiful morning. A very good morning to all of you and welcome to the All India meet of the Sai Swasthya Wellness Centers and the Sai Arogya Secondary Care Hospitals, an initiative of the Shri Madhusudan Sai Institute of Medical Sciences and Research. I hope you had a lovely tour of the beautiful and grand medical college and the work that's happening here. I think we're all here really not for a conference or a meet, but for a cause. And at the center of this cause is Sadguru Shri Madhusudan Sai. Like we just witnessed the videos on the mission and the medical college, it is absolutely inspiring to see how he is visioning to address healthcare not at a national level but at a global level and in a holistic way. So if we were to look at it, अगर हम देखें तो इसके अलग-अलग पहलू हैं. पहले outreach है, which is very basic, going to the last person in the village, which started as a Divine Mother and Child Health Program and the various screening activities that are undertaken by the centers across the country and abroad. And then we have the Sai Swasthya centers, which are primary healthcare centers, which again is the next step in this value chain. Next you have the Sai Arogya hospitals, which are envisioned to be secondary care centers. We have Shri Satyasai Sanjeevani hospitals, and then to top it all, this beautiful Shri Madhusudan Sai Institute of Medical Sciences and Research. So if you look at it, to be able to address the entire spectrum and to ensure that all of this is provided free of cost is not a feat that I'm sure nobody has taken up. It's just beautiful. And all of us are truly blessed, and it's an opportunity that we get to be part of this mission. कभी हमको जब हम सब साई वेलनेस सेंटर, साई आरोग्या, मैं सत्यसाई संजीवनी से हूँ, बाहर बहुत सारे ऑर्गेनाइजेशन से यहाँ आए हैं, हम सभी ने फील्ड में काम किया है, हम सभी ने पेशेंट्स के साथ काम किया है, उनके दर्द को महसूस किया है. जब कोई एक बुजुर्ग या महिला, जैसे वेलनेस सेंटर का एग्जाम्पल ले, एक बुजुर्ग या महिला या बच्चा हमारे हॉस्पिटल या सेंटर में आता है, वो तो ट्रीटमेंट के लिए आ रहे हैं. तो हमारे लिए क्या, what is the guideline for us? To provide high quality care with utmost love and compassion. Without these two pillars, of course, this mission is bound to fall, right? And how is that experienced? Through all of us, to every single one of us who's treating that patient. That is, if you look at it from our perspective. But if you look at it from the perspective of that patient, उस बुजुर्ग या महिला के दृष्टिकोण से अगर हम देखेंगे, तो उसके लिए वो एक मोमेंट ऑफ ट्रूथ सब कुछ है. वो हमको, हमारे देश को, सदगुरु को, सबको जज सिर्फ वो 1 या 2 मिनट में ही करने वाला है. एक एग्जाम्पल मेरे मन में आ रहा है, संजीवनी का एग्जाम्पल है. एक आर्मी ऑफिसर का बच्चा ट्रीट हुआ था. when he went back, his response was, for the first time I felt my nation served me. Right? Now that is kudos to Sadguru. What has happened to him? जब वो सर्जन या ओपीडी अटेंडेंट या रिसेप्शनिस्ट या फ्रंट ऑफिस या हाउसकीपिंग, उनको तो नेशन के बारे में सोच नहीं था ना. उनको तो सिर्फ एक थॉट था, serve each child with love and care and provide the highest quality of care, right? But for that patient, it meant the world, it meant his family, it meant the nation. That's what we represent at a micro level, right? So for that person at a micro level, it is about giving him an experience of his basic right of healthcare, which is what technically we talk about universal health coverage, ensuring that quality healthcare is available for everybody who needs it at the time that they need it, right? And that is what we are doing. If we zoom out at a macro level, we are here changing the landscape of India's healthcare, right? We are supporting, we are enabling the national health goals of the country in what we are doing at all levels. And it's truly an honor that we are able to do that. So now we've seen at a micro and macro level, who is it that links these two? It's each one of you. It's what we do every day, every minute, every second. That is the link between this macro and micro level, and that is a divine opportunity that we have got. It's a divine opportunity, it's also a social responsibility that we have chosen to be part of, right? So I think it's really amazing that we get this opportunity. I am truly inspired to see 150 members coming from all states. Of course, I'm currently based in Jamshedpur, so I'm very happy to see the Jharkhand team here. I have a special affiliation for them. But thank you all for coming. Thank you to all the organizers for making this happen. We really hope that the next 2 days are very useful. I think it's important to understand the objectives of these 2 days. First is to unify our mission, understand what is the national plan, and ensure that all of us echo the same vision in our activities at our respective centers. Second is sharing best practices. We are blessed to have teams coming from 9 states. 9 states is 9 different kinds of geographies, 9 different kinds of challenges, and 9 different possibilities of innovations. So the more we interact with each other, we will actually be able to understand best practices at an operational level, at a medical level, at a strategic level, maybe how to deal with governments, what are the challenges you're facing, supply chain, so much can come out of just pure discussion. The third is explore innovations and technology. And tomorrow, the first session will be really focusing a lot of telemedicine on point of care innovation, especially with respect to diagnostics, with HMIS. So we learn more and understand more on how we see technology powering the work that we are doing. And the last is, of course, to come out with a clear long-term and short-term way forward for each of us, right? जो इस कॉन्फ्रेंस में होगा वो ऑफ कोर्स एक ब्रॉड लेवल पे क्या ऑब्जेक्टिव्स है वो डिफाइन करेगा, लेकिन इस कॉन्फ्रेंस का जो मैजिक होगा वो कॉन्फ्रेंस के ब्रेक्स में और लंच में और डिनर में ही होगा. सो आई एनकरेज कि आप सब प्लीज़ एक दूसरे से बात कीजिए, एक दूसरे से सीखिए, चाय पे चर्चा कीजिए. यू आर गोइंग टू गेट मोर इनसाइट्स फ्रॉम दैट, क्योंकि यहाँ पे अगर 10 पॉइंट डिस्कस हो रहे हैं तो जब एक दूसरे से बात करेंगे और जो और आइडियाज़ आएंगे, एंड द स्ट्रेंथ इज दैट ईच वन ऑफ यू इज़ ऑलरेडी अ फील्ड वॉरियर, राइट? तो आपके पास ऑलरेडी आइडियाज़ हैं, लेकिन ये कॉन्फ्रेंस एक स्ट्रक्चर देगा कैसे उसको और बेहतर बनाएं. सो वेल, enjoy the next 2 days, make the most of it, and we are so happy that you're part of it. And I think at the end of the conference, when we hear the feedback, is when we'll actually understand ki tadka kahan laga, where were the exciting insights that came out. So I hope you have fun, I hope you learn. We are very excited to have a wonderful panel of doctors and faculty members from the medical college who are taking out time to address all of us. So again, welcome to all of you to the 2-day All India meet. And we commence today's program with insights and the way forward and understanding the ethos of Sai Swasthya and Sai Arogya. I invite Dr. Satish Babu, a renowned endocrinologist, Director of Academics and Strategic Growth, Sri Madhusudan Sai Institute of Medical Sciences and Research, and National Program Lead, Sai Swasthya Program, to kindly address all of us.
Thank you for that introduction. Sai Ram, good morning. It's a small India sitting here. I wholeheartedly welcome you all, and in the difficult situation, whatever the country went through, we had our own doubts, what happens if the war extends. So in spite of all that uncertainties you could make, and God forbid, the war also ended. So I'll briefly tell about this place first for 1 or 2 minutes, and then come to the Sai Shur and Sai Arogya overview part. So you all know Puttaparthi, you all have heard about Bhagwan Baba. Many might have seen, many might have been devotees, many might be having had an opportunity to serve in his mission. So this institution was started in 1971. Actually, the elder sister institution was started in 1961 in Alike, that is near Mangalore, and this was started in 1971. Baba devotee by the name Madiyal Narayan Bhatt started this institution for, he got inspired before seeing Baba by Ramakrishna missionary work, and he wanted to build educational institutions which will serve the nation, which will bring back the old glory and the legacy of Bharat. So with that intention, he started he named the institution as Loka Seva Vrinda, and sort of inspired in 1960s when he was 20-year-old young lad, another 20 people to take up a missionary work. All of them did not marry and went on to lead a life of celibacy and giving back to nation. So this group met, or Narayan Bhatt went to Puttaparthi taken by another accomplice, or Sri Narayan Rao, sorry, Narayan Bhatt was taken to Puttaparthi by Sri Narayan Rao, who was again a missionary who had joined the mission. So seeing Baba, Narayan Bhatt instantly felt he's an avatar, he's a divine master, his philosophy, his vision matched his vision, or Narayan Bhatt also had a similar vision. So he offered the institution, Alike institution. By then this was not yet started, and Baba only guided for this campus to be started. And in fact, in 1968, Baba had gone to Hubballi for a program there. When Narayan Bhatt approached Swami and prayed for this campus, he named, in 1968, Baba named this campus as Satya Sai Grama. So after that, it's 1971, the school started. Baba has come almost 30 times to this institution. Both put together became a very famous and sought after institutions. The school was from 5th to PU, both the places. And in 1985, Baba made this institution as the university campus as well. So after Baba left body in 2011, the work, whatever the inspiration of Baba, was taken forward by Sri Madhusudan Sai, who himself being a student and alumni of Satya Sai institutions. So from last sort of 15 years, you heard that there are 5 super specialty pediatric cardiac hospitals, 5 mother and child hospitals, which were started up to 2019, up to COVID time. During COVID time, here both Alike and Muddenahalli were only educational institutions churning. I'm an alumni of these institutions, so there are around 1,800 to 2,000 doctors from both the institutions, and many engineers and probably 100 IAS officers. That was the primary sort of role the institution was giving after 2011, or the healthcare was added to the service or added to the mission. So in 2019, when COVID struck, Sadhguru felt that there is a need for a proper tertiary, multi-speciality, oxygenated beds, and that's when the big hospital was envisaged and built within 1.5 years. And at the same time, you can imagine with 5 pediatric cardiac hospitals, and probably at around that time, maybe 2 mother and child hospitals, we needed healthcare professionals who are dedicated, motivated, who stand for the cause, who are sort of have the tenacity and work as missionaries. So that's when Sadhguru felt we should have our own healthcare university, medical college, nursing college, allied sciences. So in 2022, Modi ji came, our beloved Prime Minister came and inaugurated the medical college. Now this is a teaching hospital, 360-bed multi-speciality teaching hospital. So again, going back to that missionary work, what Madhyal Narayan Bhatt started, this place is sort of a foundationally, it has all the staff were in the educational mission were, as I said, celebrate, and they sacrifice like our soldiers sacrificing their lives in the borders to the cause of education, to the cause of building Bharat as a strong, cultured, character-filled students becoming sort of citizens of this great country. So again, that sacrifice, service, love all, serve all, are sort of embedded in this place, and the whole journey of last 50 years of this institution is in that regard. So that strong foundational value was so strong that it could envisage medical college to be free of cost. It could envisage medical college and healthcare, multi-speciality healthcare to be free of cost, and made that reality. So it's a collective penance, collective perseverance, collective prayer of last 50 years by many of these souls who sort of shouldered with Baba in the missionary work, shouldered, I would say, and of course followed. It's a word of audacity, I will say, but that's the commitment, that's the life they led, and that leading to this expansion, leading to what world would dare not to do, of giving giving medical college free of cost, just to make sure that if you minus the commerce, the commitment and motivation in the children will be resound. It will be ensured that they will have that kindle of service motto in their hearts and go out wherever they can and wherever they are posted to serve selflessly is the only primary objective. So when all this put together, your pediatric cardiac hospitals, mother and child hospital, tertiary care hospitals, is sort of a eye on the pyramid. How many hospitals, how many beds there should be to take care of the ill health is another challenge, another aspect which you should see in that angle. So if there is no strong primary preventive healthcare system, you will choke the secondary and tertiary hospitals, and that's what is happening in our country. There is sort of over a time with privatization more so in the healthcare, the primary healthcare, preventive healthcare is taken a back seat. But organizations like us, organizations which are philanthropic, which see purely wellness of society, of course have to invest, have to put their minds and souls into primary and preventive healthcare. And one of those institutions, I can boldly say, across the globe, not many do tertiary, high-end super specialty services and primary healthcare, preventive healthcare services as a full spectrum of care providing. And that's what we have Sadhguru has envisaged and guided us, that we should. And in fact, to quote one incident, when Puttaparthi Super Speciality Hospital was inaugurated, apparently, Prime Minister P.V. Narasimha Rao came to inaugurate, and there was obvious, politicians, these leaders come late, and Baba was waiting at the entrance, almost half an hour he waited at the entrance. And at that point in the discussion with the devotees, prominent devotees who were part of the super speciality hospital building, he apparently said, it seems, I wish a day comes when this hospital main door is locked. Means all should be healthy. Nobody should come seeking, having problem and seeking care in this hospital, even though it's a magnificent hospital built after spending so much. So with the same vision, with the same guidance or same benevolence, our Sadguru also felt primary preventive health care should be strongly supported so that people don't become that ill to go to hospital. They should have a wellness programs around ill health, around to prevent ill health. So that's the sort of vision. With that vision, the Sai Swasthya wellness centers were sort of conceptualized, and and of course, preventive healthcare is one aspect, and Muddenahalli, Satyasai Grama having tertiary healthcare, Raipur having pediatric cardiac care, mother and child centers are scattered. But what about just in case if somebody has some acute problem, somebody developing acute appendix, somebody developing some infections which needs IV antibiotics. So we should have secondary healthcare system also in all of them can't come to tertiary care, and we have only limited tertiary healthcare centers. So secondary healthcare, Sai, Arogya centers, hospitals, small 20, 30, 50 bed hospitals were conceptualized, and one hospital was started in last December. So you'll hear more as we go in day 1 and day 2. So this is the background which we wanted to sort of share with you, so that you, and of course in the next 2 days, you'll get more information, more ways of you understanding and you sort of joining hands. That's the sincere and heartfelt appeal we want to make. Swami Sadguru keeps saying that with collective contribution by many, only this mission can go ahead. So with that introduction, I welcome you all again, and I hope you had a good rest, you had a good travel. If there is anything which is still inadequate, please let us know. We will definitely try our best to keep your 2 days comfortable here, enjoyable, and going back motivated, so that you can become part of our mission. It's a mammoth task. 6,000 Sai Swasthya centers, 600 Arogya centers, and probably 4 or 5 tertiary centers is what Sadguru is planning in next 5-10 years. So people, like-minded people who are seeing their life behind a purpose, behind to do more than what a life gets defined as, is what we are seeing. And I'm sure you all will join us in this journey. Thank you, and we'll meet again. Thank you.
Sairam, we start the clinical sessions, and before we get into that, I think I wanted to share a few statistics that I came across online, which sort of set the context of why Sai Swasthya and Sai Arogya centers are important. There is a study which says that in India, 63% of total deaths could be accounted to non-communicable diseases. This is a report by the WHO in 2023. The Indian National Health Policy 2017 focuses and emphasizes on rural health and wellness centers in order to deliver comprehensive primary care and address NCDs, which is exactly what we are all doing. An academic research published in the Lancet Global Health highlights that early screening at primary level can reduce treatment costs up to 60% and improve 5-year survival rates for conditions like hypertension, diabetes, and cervical cancer. Again, these are all departments that all of us are running in our respective Swasthya centers. So while we are providing quality care, we also must understand that we are contributing economically by saving costs for the whole health system and definitely for the patient who's coming to us. Thus, it's sort of very important to continue to focus on rural outreach. If we sort of look back, what are the 3 pillars of Sai Swasthya, right? The first is early detection. सबको पता है, जितना जल्दी हम डिटेक्ट कर सकते हैं, वो हमारा singular aim है साई स्वास्थ्य के लिए. दूसरा, care continuum, whether it is diabetes management or hypertension management or any other chronic condition that you're managing, you're basically ensuring कि जो उनको एक बार care मिले, उनको बार-बार वो मिले और वो accessible, affordable हो, in our case, free है ना? So first is timely detection, right? Early detection. Second is care continuum, and the third is timely referral. कि अगर हमको पता चले कि ये हमारे सेंटर में ट्रीट नहीं हो पाएगा या like Dr. Satish Babu said, इनको secondary या tertiary care की ज़रूरत है, we have to know when is the right time to refer out, which institute do we refer out, and handhold them जब तक कि उनका treatment खत्म नहीं होता. Post the treatment, we should also have the guidance on follow-up क्या है. बहुत बार हमने देखा है सर्जरी हो जाता है लेकिन वो फॉलोअप के लिए नहीं आते हैं, मेडिसिन नहीं ले रहे हैं. ये डायबिटीज़ हाइपरटेंशन में तो बहुत कॉमन है कि हमने तो मेडिसिन दे दिया, कितने लोग ले रहे हैं उसको एनीमिया. पीपल डोंट रियली, इट्स ह्यूज स्टडीज ऑन जस्ट ensuring की यूटिलाइजेशन हो. सो अगेन रिपीटिंग माई सेल्फ, 3 pillars. One is early detection, ensuring care continuum, and timely referral, right? Now I'd like to invite Mr. Shubhajit Roy Mukherjee, Director in Arogya Vahini Trust, to share with us some on-field experiences on how a marriage between these 3 pillars ensured and has saved lives of families or patients, right? Mr. Shubhajit.
A very good morning to each and everyone and warm greetings from Satya Sai Grama. I'm really very, very happy to see all of you here, especially as Soumya was mentioning in the morning about the on-ground warriors. That's been the story of the preventive primary healthcare services, which I was so fortunate to be involved in, Swami's mission. And since the last 10 years, there's been a lot of experience through this journey of extending quality, completely free of cost healthcare till the last mile and for the last person. I'm very happy that we here are joined by Dr. Sriram, Dr. Amol, and our doctors who have been regularly working with us, Dr. Kakuli, Dr. Deepa, Dr. Pandey. All of them, we are almost working day in and day out to reach out to the last mile. I would like to share few, not stories, but incidences which will really tell you the context of what Soumya was trying to say. During those times we were working together, I remember Dr. Sriram was with us on the ground, Dr. Amol was with us on the ground. And like she was mentioning about the point of care devices, we were trying to screen patients. The first step of preventive primary was to screen patients with these point of care devices. And one of the places in West Bengal, one of the points where we regularly used to reach in a fixed frequency was Mogra. My brother Sanjit is also here. He would remember on that particular day, one of the lady who came to the camp, we just found her to have hemoglobin around 4.4. sir would recall that instance, and sir was of great help that day. And we immediately picked that patient with an ambulance, and she was, taken to the next secondary care hospital, where blood transfusion was immediately done, and she revived. That was one instance. The second was, again, I would say, there was a lot of social engineering done with regard to the model of execution of, primary healthcare services, which says about screening, detection, treatment, confirmations. So typically one would understand in West Bengal the coastal areas of Sundarban. And it is truly very, very difficult to access to around 400 islands, I must say, these people stay. So we chose a port of entry of Sundarban, which is called Chunakhali. And there we thought that we would have the hub of our camp for primary healthcare services, and the screening would be done by the team going across the river to different islands. And that also particular day, I'm so happy that even Dr. Kakuli is here, Dr. Deepa is here. They were there that day. We were, screening patients in another island where the main camp was done in the base of Chunakhali. And upon screening, Dr. Kakuli was identifying one woman whose BP was 294. And me and my colleague, Sister Deepanita, we were walking down trying to understand, talk to people inside the village, house to house, door to door. And we found that that lady was coming with a piece of paper in her hand, thinking something. She was lost in her own world. And we, in our gesture, just asked her, you had a good time with the doctor? You could explain what your concern was. She just handed over that prescription, and she said in Bengali, "Matha khub jala kore," like there's a lot of pain in the head, and we could see that figure of 294. And as a part of our NCD Care Continuum program, we ensured that monthly medicines are given in a continued support manner, and that was to be done from the other part of the island, Chunakhali. So we mentioned to her, you can go to the other part, you register yourself as one of our patients, and every month you will be supported, you need not worry. There was a very blank look from her towards us, and I could see a thin film of water in her eyes. And I also feel very emotional at times whenever I repeat this story. She said, if I have to cross that river, I have to give certain amount of money to the boatman. And if I have to give that amount, I have to get that money from my place, which is another boat ride away from this island, the other side. And then she started thinking. So there was a gap and a silence of perhaps 5 to 10 seconds where both hearts could understand the story beneath. The next question from me was, okay, Ma, what did you have for bread from the morning? She said, water. And there was silence thereafter. So that is what I must say, that screening till the last mile is so very important to detect these beneficiaries who are far away, truly in inaccessible areas, down with poverty, totally unaware of what they are into. The other instance I would say was about a child, again in one of our villages, who did not know what happened to her, the parents. And that child, we detected from the ground, we connected that child to the tertiary care center. Again, as sir was mentioning before, simple hernia. She got an operation done completely free of cost. And the last instance I would say is about screening for women in rural areas. Again, Dr. Sriram would acknowledge this story. When we were starting cancer screening in the villages, we were very skeptical about how the rural women will respond. And then there was a point of time where our mobile buses would go into the villages. The bus is absolutely beautifully fabricated, very much customized to support the privacy and the dignity of women patients. But yet, we could not, in the beginning, for at least 2 to 3 months, I would say, sir, you would remember, we could not break through. And here, I would acknowledge again Dr. Nazreen, Dr. Kakoli, Dr. Deepa. They went door to door. That is the significance. They went door to door, and we had a beautiful, I think, screening form, which was so beautifully done that you just go and have a beautiful chat with that lady in the house who is perhaps ignored, who feels perhaps shy. But here were some friends who were doctors by profession, but love in their heart, coming as friend to their door and talking to them. You won't believe, brothers and sisters, in a span of, I think, 1 month time, we screened around 1,000 women. And there were 26 referrals. So that is the power of rural screenings. Thank you, Sister Soumya, for giving this opportunity. And I must also say that the power of love, commitment, dedication is the true fuel of this mission. During COVID, during lockdown, this team of Swami continued to reach with 333 camps non-stop, supporting all the NCD patients, chronic patients who were supposed to get their monthly medications. And we are very happy that with Swami's grace, everyone was supported. And throughout the years, in the last 8 years, I would say, continued way, over 4,000 patients are being supported through this NCD management non-stop, regardless of any calamity or everything. Thank you so much. I look forward to the next 2 days. Sai Ram.
Thank you, Shubhajit. Sadhguru always says that the entire mission works on a threefold model again. सरकार, समाज और संस्थान, है ना? बिना सरकार के ये काम करना भी मुश्किल है, because at the end, the ownership for all social goals is the government. And we are all really empowering the national goals that they have set as a country, right? हम सब ने आयुष्मान भारत के बारे में सुना है. We've all heard of Ayushman Bharat. A common aspect of Ayushman Bharat is, of course, the patient, the curative scheme, जहाँ पे वो hospitals को reimburse करते हैं अलग-अलग procedures के लिए. But we don't know much about something called as Ayushman Arogya Mandir, which is a very, very important aspect of Ayushman Bharat. Interestingly, the objectives of Ayushman Arogya Mandirs and Sai Swasthya is very similar. It is to ensure preventive, promotive, curative, rehabilitative, and palliative care at rural levels at a primary health care level. And to further share with us insights and help us understand more about what happens in a Ayushman Arogya Mandir. Because this is how, if we understand in our respective geographies, how are the Ayushman Arogya Mandirs running? What are their strengths? How can we partner? How can we support them together? How can we achieve whatever are the objectives for that geography? It becomes important for us to handshake with Ayushman Arogya Mandirs. I now invite Dr. Anna Rao Kulkarni from Department of Community Medicine to share more details on Ayushman Arogya Mandirs, which is India's network of primary healthcare systems.
Yeah. Naham karta harih karta tat puja karmachakilam tathapi matkrita puja tat prasadena nanyatha apada mauli paryantam gurunam akritim smaret tena vignaah pranashyanti siddhyanti cha manorathaah. At the outset, let me have my humble pranams at the lotus feet of our Divine Master, Sadguru Sri Madhusudan Sai. Today, I am supposed to be talking about Ayushman Arogya Mandirs. And as Sister has already mentioned, they're very, very similar to what we are doing in Sai Swasthya. So we will try to understand what Ayushman Arogya Mandirs are doing and how can we learn certain things if we are not already doing and complement the government health system to achieve health for all. Now, Ayushman Arogya Mandir is an attempt to move from a selective approach. So we had the national health programs for different diseases, selective. If you say, take, for example, revised National Tuberculosis Control Program, now called as National Tuberculosis Elimination Program, if you effectively implement that program, only people will not get tuberculosis. But can we say they are having wellness? Are they healthy? Okay, any disease if you take, any health program if you implement effectively, okay, only that particular disease we were focusing. So it was selective. Even the vaccination, if you vaccinate against that particular disease, okay, that is also not guaranteed. Even vaccinated people are getting those diseases. But health, definitely we cannot say we have made people healthy. So now there is a shift from selective healthcare to comprehensive healthcare. Comprehensive healthcare is providing preventive, promotive, curative, rehabilitative, and palliative healthcare from womb to tomb under one roof. Okay, that's the shift that we are having now. It has two components which are complementary to each other. Under the first component, 1,50,000, this was the target, but actually we have exceeded the target. That I will show you a little later. 1,50,000 Ayushman Arogya Mandirs were created to deliver comprehensive primary health care that is universal and free of cost to users. That's what Sai Swasthya is also doing. Okay? So see the similarities here. And with a focus on wellness, this is very important. We are focusing on wellness and the delivery of an expanded range of services closer to the community, as close to the community as is possible to make it accessible. The second component is the Pradhan Mantri Jana Arogya Yojana, which provides health insurance cover of rupees 5 lakhs per year to over 10 crore poor families. You understand, families, not individuals. So the primary health care is provided at the sub-centers and the primary health centers, the original sub-centers and primary health centers, which are now called as Ayushman Arogya Mandirs. And if there is need for secondary and tertiary care, they are referred to the higher centers where the treatment up to 5 lakhs is covered free of cost. Again, that means there is a continuum of care without any cost to the patients. This is how, the Ayushman Arogya Mandirs work. See, in the primary health care, that is at the primary health center and sub-center, preventive, promotive, curative, rehabilitative, and palliative care is given. Progressively, there are 12 components that I will packages that I will show you just now. And if there is a need for referral for secondary and tertiary care, the PMJ care, takes care of. Now, this was started in 2018 and in 21. Okay, this is what I'll have to rush through because I have only 10 minutes, I'm told. Okay, doesn't matter. I will try to cover as much as is possible. The purpose is to understand how similarity, what is the similarity between what the Ayushman Arogya Mandirs are doing and what we are doing, and what are the things which we can learn and implement in our day-to-day activities. The National Health Policy of 2017 envisioned Ayushman Arogya Mandirs as the foundation of India's health system. Remember, this is a foundation. Preventive medicine is the only answer, I'm telling you again, preventive medicine is the only answer to the pandemic of non-communicable diseases. Whatever number of hospitals, whatever number of specialists you have, whatever number of best medicines you get, you will not be able to tackle the problems unless you prevent them. So prevention is the only solution to this particular problem. So therefore, we are focusing on prevention. These centers deliver a range of comprehensive healthcare services like maternal and child health, which was already there before also, and services to address communicable and non-communicable diseases, and services for elderly and palliative care. This has been added. See, Ayushman Bharat Health and Wellness Centers provide free essential medicines and diagnostic services, teleconsultations, and health promotion, including wellness activities like yoga. Now, these are the 12 packages that are provided. The first 6 were already there, and the bottom 6 are newly added. So here you see, from head to toe, from womb to tomb is important, all the 12 services. And second, population-based approach, all wellness and illness services for all the people. So this is the essence. So equitable, efficient, effective. Okay, all 3 words are important. We have to provide equitable health services. Equitable means provide the services to those who need them most. Okay, and if possible, then provide it for them, those who do not need that much, because some of the people who can afford, they can go to other services, other healthcare services, but those who do not have any resources, like Subhajit was narrating the story of an old lady. So that, is the priority. Equitable distribution, efficient and effective services. They provide universal free primary health care, promote wellness and prevent illness, strengthen accountability, provide first contact care, close to the people's homes, enable treatment adherence follow-up, enhance continuum of care. This is two-way. This is very important. I have put it in the different color because we always have referral system from primary healthcare to secondary or tertiary healthcare system. But the doctor at the secondary healthcare system diagnoses, treats, and sends the patients back. The story ends there. But the two-way referral system means the doctor at the secondary healthcare system has to refer back the patient to the primary healthcare system. This is what you had sent. This is what I have done. This is my diagnosis. This is the treatment. This follow-up is required at your level, and at this time, you are supposed to send the patient back to me. This referral is very, very important. That is what is called as continuum of care. Now, key reforms. This is actually Ayushman Arogya Mandir is nothing but reforms in our primary healthcare system. The Ayushman Bharat Health and Wellness Center program is a set of multiple reforms spanning all aspects of the healthcare system, such as services, medicine, diagnostic, community participation, and ownership and governance. Now, these are some of the reforms you can see here. Expanded and free service delivery, continuum of free telehealth, expanded human resources, free medicines and diagnostics, provider payment reforms. That means here we have got a team incentives. It is like a cricket match. Okay, no one person in the cricket team wins, the entire team wins. So the team of the healthcare workers are given incentives. That is a reform in provider payment system, community mobilization and health promotion, robust IT system. You can see IT system is being used at the primary health care level extensively in our country now. So this has enabled us to make the services comprehensive and easily reachable at all levels. There is an improvement in the infrastructure also. Now, when you want to give a primary healthcare services, universal quality services, comprehensive service, continuum of care has to be there, whole of the society has to be covered, and family-centric service, definitely there are going to be some challenges. So these challenges have to be understood and they have to be tackled. What are the challenges? There is an epidemiological transition towards NCDs, and all our primary healthcare system workers were tuned only to MCH services and communicable diseases all these decades. So now there is a transition. We have to focus our attention equally to that side. Selective primary healthcare, which I already said, we have to shift from selective primary healthcare to comprehensive primary healthcare. Low utilization of public health facilities. Some impression is there even now that the government health services are not good, not of good quality, and therefore people prefer even rural areas to go to primary healthcare center systems, even if they have to pay or sell their property and go to the doctor. So that has to change. That is what is high out-of-pocket expenditure. Overburdened secondary tertiary facilities because of this. So therefore, we have to have a complete rethink and change the entire way we are looking at. So I will just finish in 2 minutes. I'm told that only 10 minutes I'm supposed to cover. Yeah, anyway, but I'm, I think, making you understand what exactly we are focusing on. We must try to understand how the Ayushman Arogya Bharat Mandir is working and what Swasthya is doing and how can we complement the entire system. In 2017, Narendra Modi, when he thought of improving the health system of the entire country, he instructed the health sector to have the reforms. So it was decided in the National Health Policy of 2017 to have access of affordable and quality health care to all citizens with focus on comprehensive primary health care through Ayushman Arogya Mandirs. 2/3 of the health spending, that is budget, health budget has to be spent on primary health care. Unfortunately, still it is on paper. Even today, it is only 40%. And when I was a postgraduate student in community medicine, it was barely 10%. Only lip service was given to primary health care, and it is still not changing much. So unless we have, as I told you, prevention is the only way of controlling this pandemic of non-communicable diseases. We have to spend more and incentivize primary health care. Only then we will be able to have a healthy India. So therefore, improved public health infrastructure at all levels was decided and is being done. Adoption of digital technology, I think this is visible everywhere. All of you know this. Yeah, this was the target and this is what is achieved. You can see that except for 2019-20, our achievement was much more than the target. That is probably because of the COVID, initial hiccups of COVID. Only during that year, the target was not achieved. Otherwise, it's always ahead of the targets. Primary health care cannot be only achieved only by the healthcare department. So we have to have a multi-sectoral approach, and we have to involve other departments also, even the other sectors also. So multi-sectoral approach to healthcare is very, very important. Now, improvement in the manpower, I will just touch and then stop here. So Ayushman Arogya Mandir at the sub-center level, it caters to 5,000 population in plain areas and 3,000 population in hilly and tribal areas. And sub-center, we have a community health officer. This is the team. Okay, he is either BSc nursing or a GNM or a Ayurveda practitioner trained in 6 months certificate course. And 2 multi-purpose workers we have, 1 female and 1 male or both female, and 5 ashas, 1 per 1,000 population. At the primary health center, which is for 30,000 population in plain, and in urban areas it is for 50,000 population, PHC team is as per the Indian public health standards. There is 1 doctor, 1 staff nurse, 1 pharmacist, 1 lab technician, 1 lady health visitor. In rural areas, 1 multi-purpose worker plus 5 ashas at 1 per 1,000 population, and in urban areas, 5 multi-purpose workers and 1 per 10,000 population, and 20 to 25 ashas, 1 per 2,000 or 2,000 population, depending on the circumstances of the city. I'll just rush through all the slides. Okay, I don't know whether there is any provision for question-answer sessions. If there are any questions, I'll take them a little later. These are achievements, some of the important state. Yeah, okay, right. Yeah, right. So if there are any questions regarding Ayushman Arogya Bharat, okay, I'll be glad to take. Thank you. Any questions? Yeah, please. Sure, there is a slide. Okay, I'll just slide. Can you project, Harsha? At all levels, technology is being used. see here, Ayushman Arogya Mandir portal of apps we have. E-Sanjeevani is there, Swasthya portal is there, RCS portal is there, state-specific applications. Each state is developing its own application, okay, in some of the states. Now we have got Health Management Information System, CPHC for NCD, there is a portal, Nikshay is there for tuberculosis, Anmol is there, drug, vaccine, distribution management systems are there, Ayushman Arogya Mandir portal app. These are the things which are being used. See, the data will be collected at the ground level, grassroots level.
Something happens, you can't be documenting it, and the structured information is going to the data. In what way the technology is supporting the health of the population under Ayushman Bharat?
Yeah, so the decisions are taken at the higher level based on the data that is collected. So it will take some time, okay? So it will be there definitely implementing the health of the population, and it cannot be seen immediately. It will be definitely used at the higher levels to take decisions based on the data that is collected.
Thank you, sir.
So thank you, sir, for the wonderful presentation. I feel there is a gap in the integration side. So there are the n number of applications being used in the health and wellness center, whether it's a PHC or sub-center. Each disease comes with each app. So NCD has an NCD portal which is being developed by Dell and then Tata Trust support. The e-rickshaw is a different part. And when you still, there is a NCD app, still there are NCD registers.
Yeah.
So what we are doing with this kind of technology, we are adding a burden to the staff. We are not seeing whether there is an internet connectivity or not, but we still give the target to the people to do X number of teleconsultations. And so for sake of saying we have the technology, yes, we have the technology. What is the utility is more important for us. And when we are using or taking the experience from this kind of health and wellness center, if we also see how it is being used, whether really it is making a dent in the life of a community which we supposed to serve, then we should introspect, and then accordingly we should go ahead. That's my request, sir.
Yes, I 100% agree with you. And in fact, when I was working in KVG Medical College, Solya, we had the ANM is supposed to write 16 registers in the primary health center. 16 registers. So most of our time is spent in writing the registers, because the higher official do not bother about what exact work she has done, but they'll just assess her based only on the register entries. So we had developed one page for overcoming all these problems, but unfortunately that was not accepted by the government of Karnataka. So this is there is some resistance to change, and it will take some time. I don't know the reason why they did not accept, and unofficially the ANMs are using this in Solya. Anybody, if you wants to go, you can go and just check there. And they say this is very easy for us, sir. We have you have made our job very easy. But some resistance is always there, and of course we require training also for all these apps and portals to use. So it will take some time, I believe. Yeah, here one more person.
Sir, recently we are implemented ABA registrations and unique ID number, all those things in CHCs and also in secondary healthcare centers like Swasthya, like our cyber hospitals. What about the staff, and is it really possible for a doctor for registration and medication, giving medications and complete history recording in that system? This is taking much more time, and will they provide any assistance to them or not?
This problem is everywhere. Even in our hospital also we have the same problem. So I will not be able to answer this question whether they will provide or
because everywhere this is the problem, sir. In India also, in government hospitals also, this is the problem.
Everywhere this is the problem, I agree. I have worked in Saudi Arabia also, established primary health center for 11 years. There also the same problem is there. So everywhere problems are there. I don't have the answer for this question. Thank you.
Thank you, sir.
think before I move ahead, I think tomorrow the IT team might be able to talk more, especially with the HMIs. But if I was to just brainstorm, I would think that increasingly, especially in the next few years, there might be, with AI coming in so actively, there could be easy voice-to-text conversions wherein you wouldn't need as much of manpower to be sitting and typing. There are, in fact, there are tools where, and they're already existing in the West, where doctors talking to the patient, and as they're talking, it just gets recorded, and necessary prescriptions and everything just comes out. So I have a feeling it's just about time and integration. Venu and the IT team tomorrow would be able to talk more about this. Thank you, sir, for this absolutely enriching session. The next topic is very interesting. Again, before that, a quick statistic is, as per NFHS 5 in India, it's reported that 57% of women are anemic. These are, of course, just reported numbers. The major cause being iron deficiency. This is a condition we've all faced, probably are anemic also. This is something that's really so common within our own families, around the communities, rural areas. While this says 57, I've been part of a lot of screenings in Jharkhand. It's close to 76, 78% in some aspirational blocks and districts. So it varies. I think it's important for us, while we take up anemia and iron deficiency as a cause, we need to know more about it, empower ourselves so we know how to drive this mission with regards to iron deficiency. So in this context, I invite Dr. Akka Mahadevi from the Department of Obstetrics and Gynecology to share her remarks on iron deficiency in women.
Om Shri Sai, offering my most humble pranams at the Divine Lotus feet. As Madam said, the anemia is a major public health issue. And so that I'll be speaking in brief about the anemia deficiency anemia, iron deficiency anemia. So the main talk will be empowering the health and well-being of women. So we know that all women, whether it is an adolescent or in the reproductive age group or in the elderly, all of them have anemia. And nowadays we are recently seeing elderly women coming with 3 and 4 grams hemoglobin and with congestive cardiac failure. Is it because they are not taken care, or is it only nutritional deficiency? Elderly are not taken. Always we are focusing on the pregnant women. Yes, pregnant is also important, elderly and adolescent also there is an increased incidence of anemia. As Madam said, according to the NFHS 5, around 57% of women in India are anemic, and that includes all the age groups. And overall, it is, in the pregnant, it is around 52.2%, and non-pregnant, it is 57.2%. Whereas the global statistics says that it is 37% in pregnant and around 30% in non-pregnant women. So basically, actually compared to the NFHS 4 and the NFHS 5 data, it has seen that there is an increase, in spite of all the implementation of interventions, there is an increase in the anemia statistics. And that is the percentage of increase. Mainly the northeastern states, there is a higher increase. And what could be the reason? We'll just go through the slides. And the main risk group is the adolescent, pregnant women, and women in the rural areas. That is very important. Why? Is it because of nutritional deficiency is the main thing. Are we focusing on the nutrition? Or is there any other reason why anemia is the main cause? In Karnataka, it is around 47.8% in women. So definition, coming to the definition, anemia is a condition characterized by deficiency of the number of red blood cells or a decrease in concentration of hemoglobin, and that reduces the oxygen carrying capacity. This, we all know about the definition of anemia. And the cutoff is, as per WHO, it is less than 12 gram %. Whereas the cutoffs in pregnant women is little different. It is less than 11 grams in the first trimester, less than 10.5 grams in the second trimester, and less than 11 grams again in third trimester. It can be classified as mild, moderate, or severe. And the ranges are given here. And there is a slight change in, for the pregnant women. Mild will be around from 10 to 10.9. The others are the same. Severe anemia is less than 7 gram%. So the key points in this are, it's a major public health concern. That is one important thing what we should understand. And low and lower middle income countries are the greatest burden of, mainly the main burden of anemia is in these countries, and especially in the rural setup. And the main cause will be the iron deficiency anemia, though the other thalassemia and sickle cell trait and chronic anemias are also there. There is something called intergenerational cycle of anemia, which we need to know before we tackle or before we go to the management and investigation. So we are dealing with adolescents who enter the reproductive age group with low iron stores. And why are adolescents having so much of anemia? We all know that polycystic ovarian disease, so many people are having menorrhagia in the adolescent group, and PCOS has become very rampant nowadays. That is one of the things. And second is their dietary habits. How many of the adolescents really have on their plate vegetables, fruits? More of junk food is there. Is there iron-rich food in there on their plates? That is one thing we should really think. The same adolescent girls become pregnant, and they are already become pregnant with the anemia, with the baseline anemia. So as, Swasthya clinics, here we have to target. If any adolescent comes with anemia, we know that she's going to get married and become pregnant. So that is where we can tackle anemia, treat them at the earliest. These pregnant women with anemia will give birth to a baby with low iron stores and low hemoglobin levels. And that again remains uncorrected in infancy and childhood because of the dietary habits. Then these children become adolescents again with low iron and hemoglobin levels, and they lose blood through the menstrual cycles. And these are it becomes a vicious cycle. This is the main intergenerational cycle of anemia. This is what we need to cut or break. So the main causes of anemia, iron deficiency anemia, is inadequate iron intake, blood loss through menstrual, or it may be through deliveries during the delivery, either a postpartum hemorrhage or abruption, or impaired iron absorption. This is any other gastrointestinal disorder, and increased demand. So mainly the demand compared to men, the women will have 2 milligram per day requirement, whereas the men have 1 milligram per day. That is the demand. So we all know about the signs and symptoms: fatigue, shortness of breath, cold hands and feet, pallor, brittle nails, hair loss, and headache, decreased concentration. Among the children we have, this is one more thing, they are always tired. They may be obese. PCOS children may be obese, but they don't have the energy to go and do exercise. They're always tired. They finish their schooling, come and sleep. That is, the tiredness could be a reason, anemia could be a reason for their tiredness. So what are the consequences of anemia, the global impact? Mainly it will affect the school performance, especially in the children. There will be developmental delays, behavioral disturbances, such as decreased motor activity, social interaction, and attention to tasks. That is one thing. Then there is, as far as adult is concerned, there is decreased productivity. Because they are tired, they may take off during their menstrual cycles, because they are not able to sustain that little loss. If it is menorrhagia, that is a different thing. But otherwise also, if there is baseline anemia, the little loss during the menstrual cycles, they may not tolerate, and they may become tired. And during pregnancy, the important thing is what it can lead to. It can lead to premature birth, low birth weight, maternal mortality, and postpartum hemorrhage. This is very important. Anemic patients are prone for postpartum hemorrhage. Then impact on the adolescents. There is impaired cognitive function and concentration, and affects their academic performance. And there is reduced physical stamina and participation in activities. See, when these children actually need to be very active and go into sports, hardly anybody, especially if they are anemic, they will not enter into the sports events. That is one of the problems. And there may be a delayed growth and development in severe cases and increased susceptibility to infection. Recurrent infection may be one of the things in anemia. So coming to diagnosis, we all know that complete blood count, peripheral smear, and iron studies if it is not getting corrected. And diagnostic features of iron deficiency anemia will be low hemoglobin or hematocrit, low MCV, low serum ferritin, low serum iron, and high transferrin or total iron binding capacity. These I just gone through those points. And coming to treatment, very important is the prophylactic. And it can be divided as prophylactic and curative. So what are we doing as far as prophylaxis is concerned? There are, according to the Anemia Mukt Bharat, there is prophylactic iron being given to all the children. Either it is a bi-weekly or weekly iron tablets are given. And one more thing is, deworming is done for the children and also the pregnant women. And spacing of births as far as pregnant women are concerned. And dietary prescription. What are we telling about the diet? We are telling them to have iron-rich diet and also the timing of when they are taking the tablets. Then in curative, we have the treatment for with iron tablets also. But basically, if it is not getting treated with oral iron, then we are shifting over to injectable iron. One important thing I would like to stress here is, especially in the pregnant women, how many of us are actually taking time to tell them to take 1 glass of lemon juice or a tomato with her iron tablet? That itself increases the iron absorption. Just a simple thing. And we hardly, are you taking tablets? Yes. Do you need tablets? We just order, especially here, because we are giving supply of tablets. But we hardly take time in the busy, especially in the gynae OPD or obstetric OPD, we hardly take time to tell them about the diet. It may be a second visit or a third visit, but still we have to highlight on the diet. So with every iron tablet, if she can take the lemon juice or a tomato, that vitamin C can help in the absorption. The next thing is, she should take the tablet either half an hour or 1 hour before food or 2 hours after the food. This is very important. And most of the women are having hypothyroidism. And we tell them to take on empty stomach. So the patient may take her iron tablet also along with her thyroid tablet. So we should tell them clearly that the thyroid tablet should not be taken with any other tablet. It should be on empty stomach. And after around 4 or 5 hours, the iron tablet has to be taken either before or after food. And calcium tablet should not be taken with iron tablet. Next is tea or coffee should not be taken with her iron tablets. They take it with their breakfast, with their tea. So these are small things which we will have to educate them on. So coming to the parenteral iron, once we start giving them oral iron, and if the hemoglobin levels do not increase for 1 month, we have to shift over to parenteral iron. And we know that all government hospitals do have iron sucrose. It is freely available, and we have to make use of this. This is an aggressive way of management. Earlier, prophylactic also we used to give iron, curative also we used to give oral iron. But now, whenever it comes to curative, we will have to shift to the parenteral iron. That is iron sucrose, which is usually given as 200 milligram in 100 ml normal saline, intravenous over 8 to 10 minutes. And it is usually given on alternate days. And we have this ferric carboxymaltose. This is more costly. People who can afford. This is not available in the government hospitals. And we have the Ganzoni formula to see what is the dose calculation for the anemia. A total iron dose will be body weight into the deficit into 2.4, which is a constant. And we are adding 500 milligram for the replenishment of the iron stores. Lastly, coming to the blood transfusions. Blood transfusion, we are seeing so many adolescent girls who have come with 5 and 4 hemoglobin. We have to do blood transfusion, especially if it is severe anemia. And in pregnancy, we are going to give if it is less than 7, but if it is nearing term, we will have to give blood transfusions. And dietary sources of iron. We have a big list of iron-rich. If we ask any patient, can you give me 3 diet sources, diet or a method where iron can be increased, hemoglobin can be increased by eating these things. I don't think they can give at least 3 important. And I remember in one of Satya Sai Baba's discourse, he has specifically told that in rural area, for the ASHA workers or the ANMs, to tell everybody to have one papaya and a drumstick tree in their backyard. By that itself, we can increase their iron intake. Just drumstick leaves, which is one of the superfoods. So we have so much rich, iron-rich diet. And greens, we take spinach and all. It's preferable to saute it with oil and then take rather than taking it raw. And even the cauliflower leaves also they are suggesting. And some fruits like pomegranate and all are quite costly. So watermelon is cheaper. So we can ask them to choose what they can afford. Sitafal is also compared to, cabbage leaves. Amla is a very rich source of vitamin C. Now the 6 interventions which Anemia Mukt Bharat has helped us to overcome this anemia. Main thing is the prophylactic iron, deworming, and there are a lot of awareness camps which help in testing and treatment, and promoting delayed cord clamping. This is one more thing which we can break that cycle of intergenerational anemia. Promoting delayed cord clamping at the time of delivery. Even that little amount of blood which goes to the newborn will help prevent anemia in the newborn. And then coming to the intake of iron-rich foods, and iron-rich foods are again fortified foods also. Our country is now slowly fortifying the wheat and also rice. And screening and treatment of non-nutritional causes. So basically in this, the iron-rich, protein-rich and vitamin C-rich foods have to be given to the patients. This fortification, there are some innovative things. Recently I read, they have developed some knives which are iron-rich. I mean, each time we are cutting vegetables, it gives in the iron to those vegetables. And they have found, there was a study in Africa where they have found iron utensils, where cooking in that gives more iron than meat. They have done a study. That is very interesting. Okay, so with all this, prioritizing health of its most vulnerable girls, mothers, and young children in India, we are breaking the intergenerational cycle of malnutrition. And with sustained investment, digital innovation, and strong last mile delivery, the vision of a healthier, anemia-free India is within reach. Thank you.
Sairam? Yeah, thank you. Sairam, this is not a question, but an answer to a question that came earlier regarding training for doctors and medical staff with technology and IT. So I can speak on behalf of the Sai Arogya hospital at Bapatla. So we just rolled out the OPD software from reception to the pharma, a complete end-to-end part of it, where the doctor's module was also a very critical part. So the entire hospital has adopted the IT very effectively. We've also been giving targeted trainings for each of these entities and users of technology. So if there's any need in future as well, we will definitely invest in training and help them make sure that they adopt the technology effectively. So that's it, yeah. Any other questions?
Thank you very much, Akka Mahadevi. Actually, you told about CHD will be eradicated by managing the anemia in the pregnant women, and what can be done to eradicate this CHD in children. Congenital heart diseases can be eradicated if we take care of pregnant women.
Actually, nowadays, they are telling that nutritional, whatever nutrition we give to the pregnant women, that can prevent the congenital. But there are many risk factors. And we are trying to increase the protein level. Actually, there is no confirmatory evidence. In our hospital and in Raipur hospital, they are trying to come up with a study. They are trying to give iron-rich food and protein-rich food for the pregnant women, do fetal echo, and then see, they are doing echoes for the babies which are newborn and trying to see with a control to see how can we do anything about there is no proved as such.
Sarah, madam. Madam, as per your statistics, 57% of women are having anemia problem. Out of them, non-pregnants were having less percentage of anemia, and pregnant were having lesser, non-pregnant were more. The data is fluctuating. And what do you feel and cause for that less percentage of anemia in pregnants?
Maybe we have started so many interventions focusing on the maternal and child health. That could be one of them. And there is so much neglect in especially the elderly and adolescent. Also, there is a there is a large increase in the adolescent anemia. So that may be the reason why, especially compared to the NFHS 4 and 5, there is an increase in anemia for the adolescent also. That could have given. And we are focusing so much on pregnant women also. I don't know if that focus is happening in the schools and in the adolescents. And elderly, though they are, I don't know. Elderly, how many of us are really going to the elderly people to give them anemia and all? I mean, iron tablets and all.
Madam, maybe it is a reason that we are giving iron and folic acid tablets to pregnant women, those who are coming to our centers. But the other gynec patients, those are not coming.
Exactly.
They are generally weak. And how to address them?
First is detection, sir. Important is detection. And at the village level, what I am seeing here is nobody takes care of them, especially the adults. And it is neglected because they continue to work. They have little tiredness. They continue to work. And their diet is mainly of carbohydrate. Hardly any iron-rich diet is not there. So making them aware of the diet choices, even if it is adult. Because we are focusing so much on the pregnant women. That is correct. But there also we'll have to focus.
Ma'am, we visit rural health camps. We do and there we do hemoglobin screening also. So before writing or diagnosing the patient with anemia, if the patient of the female, the hemoglobin level is below 7, or before tagging them or diagnosing them as severe or mild or moderate anemia, are other tests necessary other than hemoglobin level?
First you can, if it is a...
Can we start with the medication on the first visit?
Yeah, if it is 7 and all, you will have to... And for one more important thing is all pregnancy you are talking about. In general, you will have to start the treatment, wait for time. If it is less than 7 and if they are in failure, then you will have to give blood transfusion. That is different. But if it is in mild and moderate anemia, you will have to treat them, wait for a month. If it is not, then you can do the other tests are quite costly. You will have to, depending on this WHO guidelines. You will have to. And one more thing important about the pregnant women is they will come with a good, good stores, like HB is 12 gram%. They will ask, I have good hemoglobin level, do I need to take? It is very important, we stress that even if it is pregnant, even if their stores are good, if their hemoglobin is good, they have to take the iron and calcium tablet, iron tablet, because only 10% is absorbed and there will be a 10% drop in the hemoglobin levels as pregnancy continues. That is very important. Even if their hemoglobin levels are normal, we have to give iron. That is a very important thing. Yes. We are asking them to take 1 tablet per day and give them, along with that, give the dietary supplements. Give them the dietary supplements also. If we tell them to take 2 tablets, the intolerance will increase. So give them the dietary advice. Still it is not coming up, then you have to go to parenteral. And you can make a note if they are intolerant to every month you can give 1 injection. That will maintain their hemoglobin levels.
Thank you, ma'am. Thank you. It was very informative, and I'm sure all our teams learned because it's very relevant to everything that we face on a daily basis. Our next speaker is Dr. Naveen Kumar from the Department of General Medicine, and he shall be presenting on Decoding Common Symptoms, a practical guide for general physicians.
Sairam to everyone, Ambal Pranams to Swami. So I wanted to just, what Akamhadi ma'am spoke about the anemia. Anyone has seen how much low hemoglobin anyone has seen recently? In your practice or in your hospitals? How much hemoglobin? Okay. See, I'm just telling what ma'am told. In our hospital now, in ICU, one patient is there, 65-year-old. Why elderly people are missing about the anemia? His hemoglobin is 1.2. 1.2. So again, 2 days back, we admitted one young girl, adolescent girl, around 18-year-old. Her hemoglobin was 1.9. So you just imagine so anemia is rampant in, everyone will tell that 54%. I feel it's more than 70%. Because we'll see in OPD, especially rural population, iron deficiency rampant. In our ward only, here only our ward is there. So many 3 or 4 patients are there. All the hemoglobin is less than 4. So, so anemia is rampant in India. Most common cause is what? Anyone? Nutritional. Just they are not eating food properly. Nutritional. So that's why Swami is more stressing on nutrition. Nutrition is very important. So because of that, iron, especially iron, most common is in that also iron deficiency anemia is most common. They are not eating food. Okay, coming into my topic. So how many of our doctors, like MBBS doctors, anyone here? Okay. How many are nursing staff? Volunteers who are working? Size. Okay. So because my topic is decoding of common symptoms at a clinical approach for a general physician, especially doctors. Anyway, for volunteers also it will be useful because so many, especially in Indian OPD, most of the symptoms will be non-specific. So around, if 100 patients comes, around 30% will be somatoform disorders, like common symptoms because of some mental issues, some other things. They will express these physical symptoms and they will come that. And 30% that repeating, just body pain, joint pains, weakness. If you ask anyone in the OPD, anyone, they will tell joint pains, weakness, and those are most common cause will be nutritional vitamin deficiency only for that. And it may be age-related also. So real proper OPD patients who have proper disease will be around 30%. So you should differentiate them because what will happen if so many patients will come, we'll miss the 30 who need treatment. So it will happen in everywhere, in every tertiary care hospital, especially in India, even in AIIMS, even in Victoria, in Narayana, any big hospital also, it will happen. Because that's why decoding is very important. We need to decode the common symptoms. We need to identify the proper red flags which need attention and which need referral and which needs proper treatment for them. So that is very important. Okay. So that's what, understand the common causes of these symptoms. So I'll just brief you about the, it's layman term also, normal medical term also. So you can easily understand that. Then you should ask you can't, if patient asks complaints of weakness or fever and all, you can't ask unnecessary questions and all. It will delay the approach also, it will delay so for that, proper history should be asked and proper examination findings is very important. Okay, then urgent care or referral is needed. So when the OPD is 100 patients are there, when you enter to a hospital or any your volunteer, you can just recognize the patients. If they are sick and all, they will be tachypnic, they will be toxic, they will be weakness, something will be there. So you just glance around them and you need to identify them and you immediately take care of the first. It's not like a first preference, it should be a triage system. Red flag signs are important. So if hemoglobin is less than 4 and all, definitely they will have tachypnea. Tachypnea means respiratory, they will be breathing difficulty will be there. And they will look full pale and they will do weakness will be there. And you can identify them. So first you need to refer them. So hemoglobin will be 12. Then they have to wait. So you need to identify the patient who need treatment first. So That's why someone is telling data and all, it will be delayed, and in OPD patient, they will complain. So our waiting list will be late and all. Because we will first recognize these patients who need treatment them. So who doesn't need immediate treatment, we'll tell them to wait. So they will get frustrated and they will complain on these things. They won't be satisfied. Whatever we do, they won't be satisfied. This is common in everywhere, all over the world, it will be common. Okay. And formulate the basic diagnostic and treatment. Now, because of the 21st century, it's always evidence-based medicine. So it's not like clinical based. Earlier, just a doctor was seeing the patient, he will identify you are having anemia, will transfuse blood. Like that, they are doing that. Now, evidence-based is important. We need to identify we need to get the blood investigation, and we need to identify the cause, and then only we can treat. Otherwise, so many medical legals are there, and it's scientific also. That is very important. Okay, common symptoms in general OPD. I think anyone from North India? North India, most of the symptoms would be more of infectious. They will tell fever, cough, those are common. In South India, usually in India, almost the similar symptoms will be body pain. We'll call it HPD. HPD means Ata Pava Darad. Everyone will ask, like in OPD, they will come, body pains, Ata Pava Darad. So everyone will joint pains, body pains, they will complain on that. So that's what I'm telling. There will be non-specific symptoms. We need to identify the symptoms. So in this, if patient comes with a cough, sore throat, cold, if these symptoms are there, most of them will be upper respiratory tract infection. That means normal viral infections. It doesn't need too much care. It's a very simple thing. You can tell them, we can give symptomatic treatment to them, and we can treat anywhere. Actually in US and all, they will, on the medical shop only, they will take the medication and they will. But in India, what will happen for this also, they will start antibiotics. That is the problem. If you ask anyone, what is the treatment for cough, cold, fever, they will tell azithromycin. They will take azithromycin for everything. So that's an antibiotic, not required. Viral illness, symptomatic, simple tablet is any paracetamol or some levocetirizine is that is not enough. So coming into next, in respiratory symptoms, shortness of breath and wheezing. So if patient complains breathing difficulty or wheezing, that sound if any time, that you need to be little worried. So you should refer the patient. If you have facilities, you can treat over there, or you can refer the patients. That is very important. So in respiratory symptom, that is important. And especially in India, most of the respiratory symptom, pneumonia will come. Most common cause is tuberculosis. Tuberculosis is rampant in India. It's like anemia. Tuberculosis is very rampant. In our hospital only, we'll see daily almost 1 or 2 patients tuberculosis. So now tuberculosis, Mukta Bharat, they are planning on that. But I don't know it will happen or not. It's very difficult to treat that. So especially with the shortness of breath, wheezing, fever, and then we need to find out tuberculosis and any pneumonias. Then he needs hospital admission or proper care with the specialist and all. So that is the red flag symptom. Then coming to gastrointestinal, so abdominal pain. So one of the most, I used to tell students, most common symptom in India, one of the most common is epigastric pain, abdominal pain. What is it? Gastritis. So everyone will have, because we eat so much of spicy food, spicy items, so and we won't follow proper diet, and we'll eat whatever time. So they, in rural population, most of the women especially, they will eat only once a day. 11 o'clock to 11 or 12 o'clock they will eat once a day, that's all. So definitely they will have gastritis. So they will come with a recurrent, these are recurrent symptoms. They will come with, every day they will come with a chest pain. So because nowadays chest pain is one of the red flag sign, because we need to do ECG and we need to rule out cardiac thing. So most of the 80%, especially in Jayadeva, that is a cardiac center, in the OPD, most of the, almost like 70 to 80% will be this gastritis patient only. In that thing, in 30% who needs cardiac care, they will miss out. Because this normal patient, they will be a little aggressive also, because if they get delayed, they will get galata, they will do galata and all. So it will happen that. So that is the main problem with that. So most of the pain abdomen, there will be gastritis will be there. So gastritis, normal antacid, and by after the antacid also, lifestyle very important. They should eat at same timing, at least 4 to 5 times a day, small meals, and they should avoid all the coffee, tea, beverages, and all the spicy food, those things and all. They should maintain like that. And for every symptom, every disease, lifestyle modifications we should advise, not only medications. Otherwise, they will come back again and again. Then diarrhea, constipation, nausea, vomiting, loss of, these are all gastroenteritis in them. In that abdominal pain, you should ask them, is mild, moderate, and severe. You can ask them like for 10 score, how much your pain is, 7 or 8, in their own understanding. Because sometimes it may be other organ thing, any appendicitis, right side if lower appendicitis, other problem, anything is there, we need to see that. We should not ignore that also. We should not consider everything is gastritis only. We should see that. So we should ask for the severity. After taking antacid also, if it is not coming down, then better go for a scanning done. But nowadays, for everyone, they will do scanning because of the evidence-based. So you can go for a scanning. It's available everywhere. Then diarrhea and constipation, vomiting, loss of appetite. So diarrhea, vomiting, they will use ORS. You know, right? Anyone has ORSL Tetra Pak? Anyone has given ORSL Tetra Pak? In Swasthya, I think you will ask no diarrhea, if any complaints of diarrhea, you will tell them to ORSL. So now actually that corporate, that one company is there, it is misleading the patients. ORSL, one Tetra Pak is there, it should not be taken, it should be banned. They are using the ORS powder, this thing, normally packed food, it is for treatment for loose motions and all. They are giving in Tetra Pak. So they are mentioning ORSL, and bracket they have mentioned it's not for diarrhea, small. So everyone is misleading that. If you ask any patients, if they get diarrhea and loose motion, they will get the Tetra Pak. It costs 10 rupees and they will drink it. It will increase again. It make asthmatic diarrhea, it will increase again. So you should tell them to take ORS powder, the WHO formed ORS powder. They should mix with the 2 liters of water. Then on the basis of their dehydration, we should take that. That is very rampant in India, especially pediatric population. Because in pediatric population, that ORS or Tetra Pak, they will have pipe also. They will easily, children also will take that. So parents also will give that. Again, that diarrhea will increase. That is also very important. So in gastrointestinal, that is loose motions more than 10 times, 15 times, like liquid loose motions, along with the fever, stomach pain, then vomiting, severe vomiting, and taking medication also if it is not coming down, then we should refer them, because dehydration is very important. So if severe dehydration happen, they will go for acute kidney injury also. Simple fluid management in that patient will prevent the kidney injury problems. So many patients, what will happen? They will have gastroenteritis, loose motion. They will have vomiting also. They won't be taking water. They are not able to take water. Definitely they will have vomiting. They will be like that only. Then they will go for acute kidney injury. So they will come with acute kidney injury. So we have seen so many patients with acute kidney injury, they need dialysis also. It will happen that. That's a simple. So if they're not able to drink water and all, then definitely you can start IV fluids for them and we can monitor them. That is very important. So nausea, vomiting, loss of appetite. Loss of appetite is, if you ask now ask anyone, everyone will say, so that means I am not able to eat food only. Every time. That is also one of the symptoms of gastritis, and proper, if they are not taking nutritious food, it will happen. So musculoskeletal symptom, this is more burden, because after below adolescent age and all, it's because of the nutritional deficiency. Middle age, if they are working too much, if they are stressed out, they will have body pains, muscular pains. In old age, same thing, old age related problems, osteoarthritis, dosum, and myalgia. These are most common symptoms in the OPD. So in that also we should recognize which is causing arthritis. Any medical treatment is required. Some vitamin D supplements, some calcium supplements can prevent so much of pain also for them. And some little bit of lifestyle modification. See, if middle-aged or 45 to 50-year-old female lady having osteoarthritis of knee and all, they should not use stairs, they should not sit down, and they should make modification on that. If they make that modifications, at least 30 to 40% of the pain will reduce. But the people won't listen. They will tell, I was there for since long time like this only, I will be there like this only. Then we will tell them to not to ride, not to drive and all. They won't listen. They will do whatever they want. They will come back with the again pain, and they will take painkillers, again on and off painkillers. So we need to treat the cause. In that, if arthritis and all is there, they will have tenderness and swelling, those things and all. Then we need to refer to a specialist, and we'll rule out rheumatoid arthritis, osteoarthritis and all. We'll treat according to that. So in that headache also, patients has to get a refraction test and BP checkup done. So they will have early symptoms of hypertension can be there. Then this numbness, tingling, and dizziness. So one more thing, especially in pure vegetarians and all, in numbness and tingling is one of the most common causes vitamin B12 deficiency. If they're not able to eat that, vitamin B12 supplements you need to take, especially in vitamin B12, one of the bad thing about it, in vegetables, it won't able to find it. So in iron, at least we'll get a vegetable, this one. In usually in pure vegetarian, it's very difficult. So better to take the supplements, or you can take vitamin B12 injections also in that. So we need to identify if patient is having numbness and tingling, because it's reversible. So we need to identify the cause. We can get a simple vitamin B12 test. If they are not affordable, you can start vitamin B12 tablets or injection. So if they are having numbness, better to start injection only, because it will immediately reverses the symptoms. So rash and itching, especially in rural population, if they are not, especially fungal infections, very common. So scabies is also very common. So scabies, we need to counsel the patient properly, because if scabies comes to in their home, everyone will get the scabies. So we should clean their cloths and all the beds, everything. They should change, and they should use permethrin lotion will come. You should use once a week, they should use that. And tinea infection also, they should change their innerwears, and they should be daily bath, everything is important. That counseling is very important. If you treat, and after that also if you don't counsel them, they will come back with the recurrence. Especially in our skin OPD, you can see rampant tinea, like it will be like from, if you see that, it looks like a big skin disorder, but it may be simple fungal infection, tinea. If they have taken proper treatment, you could have been fully recovered. Okay. Then other fatigue and sleep problems and fever. So fever, everyone knows, if fever is there, if more than 1 or 2, so if patient complains of fever, nowadays better to ask for the temperature. Everyone will get a thermometer. Tell them, because sometimes low-grade fevers will be there. So they will simply, recurrently they will be coming that. We should record the temperature. If fever is temperature more than 99.5 or more than 101 degree, you should be cautious on that. So if 3 to 4 days, you can give normal simple antibiotics, it will resolve on itself. If more than that recurrent is there, associate symptoms we need to see, cough is there or loose motions or any other symptoms is there. According to that, that system involvement will be there, so we can treat on that. And fatigue and sleep problems. So fatigue and sleep problems, most probably stress-induced also, most commonly stress-induced also, because of the lifestyle pattern, and we'll wake up at wrong time, we'll sleep at wrong time, we'll use mobiles, so many problems are there. So that is also, we should take proper patient lifestyle. So how his daily lifestyle is, and we should advise for that. Otherwise, if you give normal thing, it won't happen. And if sleep is persistent, if the patient is not getting, better to refer to a psychiatrist properly. They will find out the cause and they will treat, because sleep is very important. Sleep is, it will maintain the biological clock hormone. If sleep is disturbed too much, they will end up in so many metabolic syndromes like diabetes, hypothyroidism, everything can happen. So that is very important. So that is initial assessment. If you are in a field or anywhere, just check. I think nowadays everyone has a pulse oximeter. So you can check pulse and saturation. And if saturation is SpO2 is less than 95 also, if patient, you just, it should signal, it should not be less than 90 only. If it is less than 95 also, you should be a little bit careful if patient is having respiratory problem, anything like that. And assess general appearance. You can see the patient is sick or non-sick. You can see if they're toxic and all, better to immediately refer the patient and treat the patient. So identify immediate red flags, that is hypotension, BP. If BP is less than systolic, less than 100, diastolic less than 70, you need to identify them, then you need to refer the patient. So when you are asking the history, that's what onset and duration you should ask, and fever pattern, then character of the cough, dry is there or productive cough is there, hemoptysis. If any blood in sputum, definitely it's a significant thing, immediately you need to refer the patient. And location and quality of body pain, that's what I told. In location is very important, pain if coming from the right side or left side, and severity of pain is there, immediately you need to refer. And focal weakness, generalized weakness. Actually, last 1 week back, one patient came, he was telling just generalized weakness, but he is having proper right side hemiparesis. He had a stroke, but he had mild stroke, he was not able to identify, he thought because he has not eaten food, he is feeling weakness. But he is already 3 to 4 days late, already stroke has developed, his stroke in evolution, he went into hemiparesis. That almost like right side fully body weakness was there. In exposure risks, any patient comes with symptoms, you should ask for the travel risk and animals and all, especially dog bites. So, anyone heard about the rabies deaths? Is rabies deaths are happening now? Yes, it's happening. It's happening. Last week in our hospital only, one patient came with a rabies. Wife gave the history as patient had dog bite. He didn't tell us only. Then he was having symptoms of rabies. Then we referred him for isolation. Then he died actually. So rabies is very important. Animal bites, anything is there. If it is on doubt also, you can get a vaccination. So you not to take risk on that. So physical examination, that's why hydration. So you can see pallor, anemia. You can see if the patient is pale, if hemoglobin is less than 7 and all, immediately you need to refer. And cardiovascular system, for doctors, I think abdomen, you can see tenderness, things and all. So that's what common differential, like COVID-19, before it was now it is not there. So any viral infections happen. So that is red flag signs are very important. Persistent high fever more than 7 days and difficulty breathing or SpO2 less than 94, altered consciousness or seizures, immediately you need to refer the patient. And any patient with a chest pain, don't ever neglect. If it is gastritis also, anything is also, get one ECG done. ECG is available everywhere, no one corner it is available, you can get a ECG done. So basic investigations, if you want to evaluate the patient, you can send the normal CBC, RBS, LFT, RFT, X-ray, if it is required, ECG, urine routine, and infectious workup, dengue. Now dengue season is started. Now from May, it will start dengue season in India. So we'll get so many dengue patients. And sputum AFB for tuberculosis, because tuberculosis is rampant in India. Any patient with cough, any patient with cough and fever, productive cough for more than 14 days, better to get a sputum AFB. So that is very important. And management approach, symptomatic. Every time go for first symptomatic approach. Don't start antibiotics. So because now I have seen in PHC level they are giving meropenem. Meropenem is a broad spectrum antibiotic just for amikacin. They are giving piptaz and all in normal PHC daycare and all. It's causing antibiotic resistant and it will affect our future and also it will affect everyone. That is, if you find any of them, just counsel them and report. You can report also. So that is very important. Antibiotics, if necessary only you can use, otherwise don't use only. Then monitor vital symptom progression. If patients are not improving, then refer. And main thing is, last one, educate the patients on warning, because it's on especially Swasthya team, they will be educating is very important, because diabetes patients, hypertension patients, they should take the medications properly. If they miss that, they will come back with the complications. So main thing, okay. Use a structured approach to identify the cause, then combine clinical judgment with basic investigation, identify the red flag signs. When in doubt, immediately refer. If you are in doubt, don't take risk, immediately refer. Okay, and thank you. Enjoy the session.
Neo, we have a question.
One doubt about rabies. So, in some cases, if they have drank milk from a cow who has been bitten by a mad dog, does the people will get vaccinated or not?
Actually, nowadays we will get vaccinated, especially cow is there. Some guidelines will tell not to vaccinate it, but nowadays because of the high risk, we'll tell them to, within if it happens, we can get vaccinated. If the rabies dog bite is there, mad dog, definitely will get vaccination done.
One of our staff, a pregnant woman, instead of giving iron orally and parenterally, her hemoglobin is always above, not above, below 7%. Then we did peripheral smear. We came to know that she is suffering from leukemia. We
Yes,
did
yes.
one.
Yes, yes. We'll see. After cancer patients, leukemias are very common. So that's what we need. First, most common cause is nutrition. Then after that, any infections and all we need to that find out leukemias are very common. So for that, every hemoglobin, if you are less than, if patient is having anemia, definitely you should get a peripheral smear. We should look for leukemias, blood cancer. That is also very important on that. Thank you, it's good.
Thank you so much. I also encourage all of you after the session as we move into lunch, the doctors will be here. If you have specific cases that you'd like to ask about or discuss, please do that. Our next speaker is Dr. Abhishek from the Department of Anesthesia. He's talking about something very essential, which is first aid.
So good afternoon all. So first aid is a very, very important topic, as all of us know. That too in our Sai Swasthya and Sai Arogya Kendras. So I'll keep it very simple, because first aid itself is a 3-day workshop, right? CPR, BLS, ACLS workshop is itself for 1 or 2 days, and then again it is for 3 days program, and I'm going to finish it in 10 minutes. So we'll keep it very short, okay? So coming to the definition of first aid. First aid is the provision of immediate care to the victim, like with an injury or illness. Here, you're not fully treating a patient. We're just giving immediate care, attention to the patient. So what are the principles of first aid? There are 3 principles, PPP. First is prevent further injury. Second, preserve life. And third one, promote recovery. What is the philosophy of first aid? Any condition, whether it is cardiac arrest, whether it is snake bite, whether it is scorpion bite, whether it is burns, whether it is electrocution, whether it is seizures, any condition for that matter, 4 things are very, very important. One is airway. We must make sure there is no tongue fall. We must make sure that the airway of the patient is very clear. Number 2, breathing. We must make sure we are assisting patient in breathing. Number 3, circulation. Number 4 is bleeding control, right? For any condition, this is the 4 philosophy of first aid. So what are the golden rules? Whatever you do quickly and quietly. Stop any bleeding if it is there. Apply pressure. Do not attempt to do too much in your setup. Reassure the patient. Reassurance is very, very important. Do not allow people to crowd, right? Do not remove clothes unnecessarily, right? Arrange for the removal of the casualty to the care of a doctor or hospitals as soon as possible. Refer the patient. So first aid topics for discussion today. First one is CPR. Second one is dog bite, snake bite, electrocution or burns. First aid for all fall or injuries, seizures, foreign body or asphyxia. Okay, first with cardiopulmonary resuscitation. We'll keep it as simple as possible, basic life support. So when does the heart start forming in the body? Heart starts beating in the body at around 5 weeks, 4 to 5 weeks of intrauterine life. So today is Saturday, is a weekend, tomorrow is Sunday. So all of us have Sunday holidays, right? So does heart have a holiday? No holiday, right? So no Sunday, no Christmas, no Yugadi, no Ramzan, nothing, right? Heart doesn't have a holiday. So heart that starts beating at 4th week of intrauterine life, it continues to beat throughout our life. And the moment this heart stops beating, the role of CPR comes into play. There is cardiac arrest and role of CPR comes into play. I'll just demonstrate, tell you the basic steps of BLS. First thing is scene safety. Let us assume the patient has fallen, is walking on the road and the patient is fallen in the middle of the road. Do you want to give CPR, that is cardiopulmonary resuscitation, in the middle of the road? No, take the patient to a safer place. Suppose the patient is walking along the river or a lake, side of the river or a lake, it's collapsed. Bring the patient away from the source of river or a lake. Suppose it is January 1st, New Year Day, and they're camping, there is bonfire, they're all dancing, and the patient collapses there. Do you want to give CPR in the middle of the fire? No, bring the patient away from it. There is a big transformer of electricity, and the patient is walking there and the patient collapses. Do you want to give CPR below the transformer? No, take him away from the source of electricity. So first thing is scene safety. Second thing is awakening the patient. We are supposed to awaken the patient as loudly as possible because this patient is unconscious. So second step is awakening the patient. And at the same time, call for help. In Karnataka, we have ambulance number 108 is the ambulance number. And in our hospital, we use 8888. So basically, you call for help. Third point is check for pulse and breathing. Which is the pulse that we are going to check? Carotid pulse. Carotid pulse, we are supposed to check within 10 seconds. Carotid pulse and breathing within 10 seconds. If there is no pulse and no breathing, start giving CPR. So how do we start giving CPR now? What is the site of CPR? It is lower half of the sternum, right? So what is the rate of compression that we are going to give? Around 100 compressions per minute. So the heart is present within the mediastinum, right? It is not a superficial organ. It is present at least 2 to 2.5 inches inside the surface of the skin, right? So the depth should be at least 2 inches or 5 centimeter, right? So, and they call what is called a cycle of CPR, which is 30:2. What we do? We give 30 compressions and 2 breaths. This is all that I'm speaking is out of the hospital setting, right? Out of the hospital setting, in a primary health care. So we give 30 compressions and 2 breaths, right? Okay. So what is dog bite? Now there is dog bite. What is the first thing that we are supposed to give? Clean the wound with running water and soap. Running water and soap, we are supposed to clean the wound. And there are different grades of bites, right? Grade 0, grade 1, grade 2, grade 3. Let us not go deeper into it, but better we take vaccination, right? As Dr. Naveen told, we have seen cases of rabies and we have seen patients dying of rabies. We have to be very careful. But first aid is very important. As early as possible, clean the surface with running water and soap water. Next is snake bite. Suppose there is a snake bite. What is the first thing that we are supposed to do to a patient? First thing. Reassurance. See, if the patient is tensed, there is sympathetic activity. Suppose I am standing before you all, I am tensed. There will be sympathetic activity. There will be flushing of the face. Similarly, when there is a snake bite, there will be activation of sympathetic activity. If the patient is tensed and there is increased blood flow in the body, the venom spreads all across the body, right? First thing is reassurance. Second thing, you do not tie a rope or a cloth, right? And third stupid thing that we see in the movies, right? The person comes to the patient and he puts his mouth, right? He sucks, tries to suck all the venom, right? That cannot happen, right? So best thing is reassurance, immobilize the limb. And there are 2 types of snake, like harmful snake bites, which you all know. One is emetotoxic and one is neurotoxic. Emetotoxic, bleeding manifestations. Neurotoxic, there will be difficulty in breathing, ptosis and all such symptoms. So basically, we have to take the patient immediately. And first, best thing is, you must know where the anti-snake venom is available beforehand. We can't take chances. After there is snake bite, we can't take chances taking him to a primary health center where there is no anti-snake venom. Nearest center where anti-snake venom is available must be known. Okay. Burns. Recently, our own child, 1.5-year-old, he had a burn. So my wife was cooking. She was boiling milk, and a child was sitting away from the that point of boiling milk. But my wife just turned and my son immediately jumped to the boiling milk and he burned his hands. So I had a first-hand experience with burns. So very unfortunate. But what we did, immediately we took the child to a running cold tap water, right? We did not rub it. We did not want to lose the skin, right? Even that is important. We need to preserve the skin. So running tap water so that there won't be immediate scar formation. It will delay the scar formation, right? I am speaking about scarring, not healing. So running tap water, you must apply the running tap water. Next thing is Cooling. After cooling, covering. You must cover with a wet sterile cloth or a sterile dressing, right? And immediately take the patient to the hospital. So what they say, collagen dressing is the best for a small wound, right? Otherwise, there are so many ointments and other things available. But thing is, first step is cool with running water, cover the burn, and take the patient to the emergency hospital. Next is nosebleeds or epistaxis. So there is a nosebleed. What is the first thing that we are supposed to do? Pinch the nose. Are we supposed to tilt the head backwards or forwards? Forwards. That is a common mistake we do. Whenever there is nasal bleed, we must pinch the nose and bend downwards. If we bend backwards, all the nasal secretions and all the blood goes to the throat, and there can be laryngospasm also, right? So, bending forward, pinching the nose and bending forward. Next, if there are any injuries, first aid says immobilize and stabilize the joints. You can see in the figures here, we are immobilizing and stabilizing the joints. There should not be movement. Same with the spine. So foreign body in the throat. This is again one more important topic. What do we do when there is foreign body in the throat? This is called choking. So if the patient for breakfast, if he is having bread or bun, he'll be having bread or bun, and that gets stuck in the throat, and he will be having difficulty in breathing. He'll be asphyxiating. What do you do in this case? Have you heard of this manure, Emlich manure? So what we do, basically we go behind the patient. We go behind the patient. One second. No. No, thank you, sir. Yeah, you can come, sir. Thank you. So, sir is having bread or bun for the breakfast, and sir is choking. So, what do you do? So, immediately go behind the patient. So, the dominant hand, I place the dominant hand over the non-dominant hand, go around the patient. All of you can see my hand? And pull it back. Give a big thrust. Pull it back. Pull it back. So with this pressure, the part that is choking the throat comes out. Thank you, sir.
Dr. Sriram has immense experience in working with 108, so
thank you, sir.
Active about the topic.
So this was in gist. Sorry for hurrying. So actually, I would have been more interested in teaching. So I want to close this with a small sloka. Yeah. In children. So in children, what we do in choking, we give a thrust around their back. Like this is a child, we hold the child like this, and we give 5 blows on the back of the child. Right? In children, yeah. No, we usually give a back thrust. Back thrust is preferred. Right? So sorry, I hurried up, and I want to close this with a small sloka, which is from Maha Upanishad, chapter number 6, so volume number 71 to 73, which says, Ayam nijaha paroviti ganaha lagut chetasam udara charitanam to vasudaiva kutumbakam. So it is the very nature of the narrow-minded people to consider someone as our own and someone as a stranger, but it is the very nature of the broad-minded individuals to consider this whole family as one world, one family. So all members of Sai Swasthya and Sai Arogya Kendras are one world and one family. Thank you all.
So you told that in BLS, feel the pulse within 10 seconds, carotid pulse.
Yeah.
So how will they identify?
So
And
actually,
when will
yeah,
they
that's what-
start?
yeah,
And,
So that's the thing. Usually we say it's side of the trachea. So anatomically speaking, it is at the level of cricoid cartilage between trachea and anterior border of the
non-medical people, sir.
So
Because we are training
So it needs
everyone-
training, sir. It needs training. So even identifying the carotid pulse itself is a class for 15 minutes, explaining them where does it actually come. So what I can generally say, you can just, all of you can palpate, if this is a trachea, side of the trachea, in front of this muscle, at the level of this thyroid cartilage, you can feel the carotids. Okay, so all this first aid is a big workshop, to be precise. And BLS itself is a certificate course for 1 or 2 days, right? We have a pre-test, we have a practical demonstration followed by post-test, questionnaires and question and answers as well.
For non-medicals training, sir. For non-medicals, suppose some person is unconscious outside the road. Suppose one person is...
Same thing, for medicos, non-medicos, BLS is for everyone. It's the same. There is no change. If I were to treat a patient and give a CPR for a cardiac arrest patient, and if some non-medical person has to give CPR, the procedures are same. It doesn't change.
Some guidelines in recent also, without respiration also we can start the CPR because it is very difficult to palpate the carotid pulse. Suppose in hypovolemic patient, suppose in summer many people are dehydrated, suppose he is collapsed due to some other reason. So I have read some, in a BLS guidelines, and they told that if pulse is not there, if you can't felt, if there is no respiration, we can immediately start the CPR like that.
Sir, it is very clear. So first you try to awaken the patient.
Yes, sir. First
Awaken the patient. Yes. Awaken him loudly and clearly. If the patient is not awakened, we check for pulse. If it is a non-medical person, you cannot feel the pulse, at least check for breathing. There is no breathing, no signs of life, start CPR.
That's what
as simple as that.
If there is no respiration, then immediately start the CPR.
Start the CPR.
No need to feel a carotid pulse. Like that. Thank you.
Thank you, sir. Thank you. Thank you all.
Thank you, Dr. Abhishek. I think a takeaway is also if all the centers present over here, once you go back to your centers, I'm sure there'll be local experts who obviously know medical, basics of BLS and first aid. Every staff member of our centers should know this perfectly well. I think it's not really only about Sai Swasthya, Sai Arogya. Ideally, it should be every member of the community. But to begin with, we can start, and you have periods when you have less OPD or high OPD. Something like anemia awareness, something like BLS, basics of first aid. You can conduct sessions in, especially for example, schools. They're very enthusiastic volunteers. Our experience with 108 ambulances has been youngsters are actually very phenomenal feedback because they learn quickly. So this can also be part of your overall health education program, community awareness program, because I think it's essential to what our centers stand for. But for that, by the time we come next time, we should all be experts in this, step one. And then reach out to your local experts. You don't need to have anything particular. We are talking about, like he said, it's not but only for medicos. We are doing primary care, right? So it's everybody. All of us should be very good in understanding the basics of BLS and how do we do it. So that's, I think, my key takeaway, and I'm sure all of you agree with me. Thank you so much, Dr. Abhishek. The next is, again, a very interesting topic. We have Dr. Harish from the Department of General Medicine. He has an interesting name for what he's presenting, Whispers of Pressure, the Silent Killer's Tale. Dr. Harish.
Om Shri Sai Ram. Offering my pranams at the Bhagwan's lotus feet. A very good afternoon to all my senior staff and colleagues. I am Dr. Harish from the Department of General Medicine. And answering to that previous question, how to feel for the carotids. So one add-on point is that you have to feel with your thumb just lateral to your cricoid cartilage. Just lateral to your cricoid cartilage. And one more point adding on to that is, don't palpate bilaterally. Should not palpate on both sides, because carotid is a blood supply for the brain. If you obliterate on both sides, already there is cardiac arrest and hypoperfusion for the brain. So palpating on both sides further reduces the blood supply to the brain. So if at all if you're palpating, palpate on only one side, preferably with the thumb just lateral to the cricoid cartilage. Okay. So I was given an opportunity to tell the tale of a silent killer in this community. So, and I hope you all know what is that silent killer. Anybody, any guesses? Hypertension is the silent killer because most of the patients will not have any symptoms. So, this is why we have chosen this topic, because about 30% of the Indian population is suffering from hypertension. Say about 146 crores, 30% means almost 36 crores to 40 crores of people are suffering from hypertension. The irony is that only 25% of the rural and 42% of the urban Indians are aware of their hypertension status. Rest of them, they are unaware because they don't have any symptoms. They don't come to doctors. They don't get check their BP levels. Even more worrying is only 25% of that 25% of the rural population are being treated for their hypertension. And 44% of the urban Indians out of 42% are being treated for their hypertension. Furthermore worrying is that this depicts that out of 100 patients of known hypertension patients, only 47% are aware of their hypertension status and 37% are receiving treatment, and more worrying is only 14% patients have their BP under control. It's more worrying, and it's very important to prevent, treat and continue the treatment for the hypertension, because reduction of 20 systolic blood pressure reduces the mortality rate by 50% in the middle-aged persons. The vascular mortality rates like CVA, MI will get reduced by 50% if the BP control is normal. Only if you control the BP, 50% mortality is reduced. So that is why it's very important to control the BP, not only to detect the hypertension, it is important to treat and keep the BP under control. So why it is important to treat hypertension? Because it is simple, very essential and very impactful. It has got huge impact because it reduces the mortality. So treatment of hypertension in primary care center saves more lives than any other non-communicable diseases that have been treated in primary healthcare centers. So this is the definition of hypertension given by JNC committee, latest update. So normal is less than 120 by 180. We consider it as elevated if it is between 120 to 129 of systolic, and diastolic less than 80. Hypertension stage 1 if it is in between 130 to 139 and diastolic between 80 to 89. More than 140 is considered as hypertension stage 2, and more than 140 but more than 90 is considered as hypertension stage 2. Anything more than 180 systolic and 120 diastolic is considered as hypertension crisis. So when do you want to treat the patient? Even with one reading? No, because there is some entity called as white coat hypertension. Once the patient comes to the hospital, some patients BP may be increased because of the entity called as white coat hypertension. So it is advised if the patient has got no symptoms and BP between 140 to 160, it's better to observe for the next day. Call him after a day or two. Okay, assure him, call him after a day or two and then recheck the BP, reconfirm and then only initiate the treatment. So again, stage 1 and elevated does not require immediate attention and immediate treatment. We can advise them for lifestyle modifications and dietary modifications. But above 140 it is indicated to start on a treatment. So this is the picture that shows how do we want to check the BP. So that is also important because anything other than this will elevate or decrease the blood pressure. The more important is ask the patient to sit comfortably on the chair with the back supported and the feet supported. His bladder should be empty because full bladder will increase the sympathetic system, and again that sympathetic system will increase the blood pressure. So empty bladder is very important before checking the BP. Next, other important thing is arm cuff, size of the BP cuff. So there is 80-40 rule that tells that the size of the bladder of the cuff, BP cuff, should be at least the length should be 80% of the arm circumference. The width should be at least 40% of the arm circumference. That is 80-40 rule. So choosing this BP apparatus is also very, very important. So don't have conversation while checking the BP. So our physicians, during checking the BP only, will collect all the history. What happened? Where were you? What did you eat? All this history we will collect during checking BP only. So don't have conversation with the patient while checking blood pressure. And patient should not have taken caffeine products, caffeine tea before checking BP. This is very important. So what are the types of hypertension? So because I have only 10 minutes, I will just go through, I will give only overlook of the hypertension. So there are two types of hypertension, primary hypertension and secondary hypertension. Most of the patients we deal with are primary hypertension patients, also called as essential hypertension, 90% of the patients. The genetic and environmental factors play a major role in this primary hypertension. This can be treated at the primary healthcare level. Whereas secondary hypertension, most commonly seen in young patients, they have an underlying disease. That disease has to be identified and treated. These require referral to a tertiary care centers. Young, what is the young? Definition of the young? They're not defined definitely, so the defined age has been not given, but usually it is less than 40 years. Any patients less than 40 years with hypertension has to be evaluated for secondary hypertension. So what are the causes of secondary hypertension? Most commonly the renal causes, the autosomal dominant polycystic kidney disease, nephritic and nephrotic syndromes, renovascular diseases such as bilateral renal artery stenosis, fibromuscular dysplasias, and adrenal causes such as Cushing syndrome, primary hyperaldosteronism, pheochromocytoma, all this presents as hypertension in young. Other causes include coagulation of aorta, obstructive sleep apneas, and other miscellaneous endocrine disorders such as hypohyperthyroidism can also present as hypertension. So no need to treat hypertension. If you treat hypo and hyperthyroidism, BP will come down. So even hypercalcemia and acromegaly also presents as elevated blood pressure. So medications such as adrenal steroids, most commonly peripherally, most of the diseases will be cured by steroids in peripheral setups. So this has to be cut down. So adrenal history is important. History plays a major role in this. So adrenal steroids, any appetite suppressants, cocaine users, erythropoietin, all this increases the blood pressure. So these are the secondary causes. So when do we suspect this? In a young patient with a BP of more than 130/80. So evaluation is history. So what history has to be taken in a patient who presents with a elevated blood pressure? So basically they will have no symptoms. So we have checking in our institute, we are screening not only the patients, the patient attenders who just walk into the hospital. We are checking blood pressure for all patients. So you will not believe, so daily we are diagnosing 10 to 20 non-symptomatic hypertensive patients. We are screening only the patient attenders, leave alone patients. We are screening only patient attenders. So daily we will have at least 10 newly diagnosed hypertension patients without any symptoms. So that is why the patients usually will have no symptoms. However, when the symptoms come, they will come with a hypertension crisis such as headache, dizziness, chest pain, breathlessness and epistaxis. So while taking history, if it is a known case of hypertension, the duration and what medications he is on is also important, whether to increase the dose of medications or change the course of change the other, whether it is to be changed or only the dose has to be increased. So intake of other agents such as steroids, estrogen, cocaine is important because all this leads to secondary hypertension. So dietary history is very important because high sodium, high alcohol and saturated fats will further increase the hypertension. So presence of the other risk factors or addictive habits such as alcohol, smoking is also very important in those patients. So again, family history plays a major role in a essential hypertension. Sexual function, again, to initiate the treatment, because calcium channel blockers, they have a side effect as a sexual dysfunction. So what are the symptoms when the patients come with a high BP? So usually they will not have symptoms. So when they come, they will have a end organ damage. So usually the organs involved are cardiovascular system, central nervous system, renal and high. So high they will have retinopathy. Cardiovascular system, they may present as CVA, such as they may present as only as headache or transient weakness of the upper limb, or they may present as full-fledged cardiovascular accident. So whereas MI, whereas CVS, they present as chest pain, dyspnea on exertion, they may present as acute coronary syndromes also. So whereas in the renal, once when they go into renal failure, they will have decreased urine output, facial puffiness, bilateral low limb swelling. These are the presentations when there is end organ damage. Otherwise, most of the time there will be no symptoms. That is why it is called as silent killer of the community. So what do we want to examine? So when a patient comes with those symptoms, a physical examination should be done thoroughly. So one is measurement of height, weight and BMI to calculate the BMI. So ideally, we'll advise them to keep a BMI less than 25 kg per meter square. So BP measurement, as I told, a proper method of choosing of proper BP apparatus and BP cuff, advising him to rest on the chair with a supported back and feet, empty bladder, should not have been taken caffeine and tea before checking the blood pressure. So examination of the extremities of the pulses, say radial pulse, dorsalis pedis artery, brachial is very important because if the patient has gone into arteriosclerosis, only systolic blood pressure would have been elevated, but the diastolic blood pressure will be normal. So to differentiate that, we have to feel for the peripheral pulses. So neck examination for thyroid, because hypo and hyperthyroidism again can have a secondary hypertension. So distended neck veins and bruit in the carotid artery. If bruit is present, that means there is atherosclerosis of the carotid artery. If it is more than only 50% of the carotids are occluded, we will have a bruit. So eye examination for retinopathy. So on systemic examination, only if you are suspecting a secondary hypertension. So what are the investigations that has to be done in a patient who has come with a newly diagnosed hypertension? So renals has to be checked, CBC has to be checked, HP very important because even a polycythemia can lead to hypertension. Okay. So then urine analysis and urine PCR to see for renal involvement, and ECG, if ECG is normal, echo is not required. If ECG is showing LVH features and any other abnormality, echo is also needed. USG KVB preferably to screen for renals and renal artery Doppler in a secondary hypertension or in hypertension in Heng. So additional tests in a secondary hypertension for a renovascular hypertension, renal artery Doppler, and endocrine diseases, TSH, serum cortisol levels to rule out Cushing's syndrome. So treatment of hypertension again, so initially directly will not go for drugs. So there is something called as lifestyle modifications which reduces 10 to 15 mmHg of systolic blood pressure. So that is why even a hypertension stage 1 and elevated BP will ask them to try with the lifestyle modifications. So weight reduction to maintain a BMI of less than 25 kg per meter square, and dietary salt reduction. So ideally the recommendation is less than 6 grams per day. Sodium of less than 6 grams per day is the recommendation. Sodium restriction is very important. And adopt a DASH diet which is rich in fruits, vegetables, low fat daily products and reduced content of saturated and total fats. And the physical activity and how many days you have to do and how much of duration. Ideally they advise for at least 5 days in a week and 30 to 45 minutes in a day. Usually a aerobic exercise plus a yoga may reduce the blood pressure. So 45 minutes in a day, at least 5 days in 7 days is the recommendation. So coming on to the drugs, if the BP is not under control after lifestyle modifications, then we will opt for medications. So there are the 3-4 classes of medications. So commonly we use the formula in the sense the mnemonic is ABCD. A stands for AC and ARBs, B stands for beta blockers, C stands for calcium channel blockers, and D stands for diuretics. So AC inhibitors and ARBs, most commonly used drugs in the periphery is ramipril and ramipril. The minimum dose is 2.5 mg and maximum we can give up to 20 mg. The side effects include it can lead to acute kidney injury, and you should be very careful in using these ARBs in a secondary hypertension because it is contraindicated in bilateral renal artery stenosis. Okay, so if you are suspecting bilateral renal artery stenosis, don't choose ARBs. You have to choose another class, maybe a calcium channel blocker. So ARBs include telmisartan. The minimal dose is 20 mg and the maximum dose is 80 mg. If BP is not under control, even after giving 80 mg of telmisartan, don't increase it to 120 mg. There is no use. So you will choose another class of drug. So while choosing before choosing another class of drug, so the maximum dose of a single drug, say you are treating a patient with a telmisartan 40 mg, BP is not under control. Don't add amlodipine. Increase the dose to 80 mg. Before adding another drug, that maximum dose of that drug should be reached before adding another class of drug. And while treating, don't give ACEs and ARBs both. It's no use. No use of when a receptor is blocked, if you are giving AC inhibitor, there is no use of giving. So one class, either you give ARBs, if it is not under control, choose another class of drug. Okay? So alpha blockers very rarely we use in periphery, and beta blockers, atenolol most commonly used, metoprolol, carvedilol and labetalol. And the maximum dosages have been mentioned in the bracket. What are the contraindications, and we should be very cautious is, don't use beta blockers in asthma patients. There are few cardioselective calcium channel, beta blockers such as carvedilol. Metoprolol and atenolol, usually they are non-cardioselective and they can lead to bronchoconstriction. So be very careful while using in COPD as well as in bronchial asthma patients. So don't use it in second degree and third degree heart block patients. Why? Because beta blocker causes bradycardia. Always there is, anyways there is a second or third degree heart block. If you give beta blockers, again the heart rate will decrease, leading to complete heart block. So be very careful while choosing the right antihypertensive medications in the patients. And the calcium channel antagonists, again amlodipine 2.5 to 10 mg is the maximum dose. I've been seeing prescriptions amlodipine 10 mg BD. There is no use of giving amlodipine 10 mg BD. So maximum dose is 10 mg. Silacar is 20 mg. Silacar you can give up to 20 mg. Amlodipine maximum dose is 10 mg. With 10 mg of amlodipine, if BP is not under control, you will choose another class of drug, rather increasing the amlodipine to 20 mg. So this centrally acting clonidine 0.1 to 0.6 mg is the maximum dose. And the diuretics we commonly use furosemide and spironolactone. We usually avoid diuretics as the first line of treatment for hypertension. The first line treatment for hypertension are ACE/ARBs, beta blockers and calcium channel blockers. And diuretics, the side effects of diuretics are they can lead to hyponatremia, hypokalemia and hyperuricemia, leading to gout. Thank you. So if any questions, I'm ready to answer.
Majority of the times for hypertension is undetected. After they seek medical assistance, only they land up in CKD.
So that is why screening is very important at the primary healthcare level. So it's not only the screening, but the follow-up of the patients, whether the patient is taking tablets is also very important, because only 50% of the detected hypertensions are taking treatment. So because they don't have any symptoms.
So when they come to PHC with a diagnosed CKD,
counseling is very important.
Yeah. So what would you advise the primary healthcare doctors to start them on?
See, again, depends on the, suppose a young patient comes to you with a blood pressure of 160/100. Say patient is 30 years old with no family history. Please don't start on any medications. Kindly refer him to a tertiary care center. He has to be evaluated. But suppose a 60-year-old patient comes to you with a 150/90 of BP with no comorbidities. You initiate him, you check for renal functions. If renal functions are normal, so the best drug is ACE/ARBs. Start him on telmisartan, 20 mg. If in primary health care center there is no RFT, you can't do RFT, start him on calcium channel blockers. Calcium channel blocker is Amlong. Begin with 2.5 mg to 5 mg of amlodipine. You can increase up to 10 mg by following up the patient. What, ma'am? Amlodipine has got 24 hours of action, so single OD dose is enough. Yes, ma'am.
Sir, you have mentioned about BP levels, sir. Hypertension level 1 to 3 stage at least. Sir, it depends upon age or applied to common?
It depends on the age. The JNC recommendation is less than 60 years. the target blood pressure is 140/90. More than 60 years, the target BP is 150/90. So it depends on the age as well as the comorbidities that the patient is having. So 140/90 is the cutoff for patients less than 60 years. That's the latest JNC recommendation. Thank you. Thank you for your patience here.
Thank you, Dr. Harish. We have another very important topic coming up. Dr. Naveen from the Department of General Medicine shall cover diabetes.
Sairam, everyone. So today I have been given a chance to talk about the management of type 2 diabetes in an OPD setting. So like my friend said, the prevalence of hypertension in our country. So along with the hypertension, the type 2 diabetes has been labeled as twin epidemic. Both have been labeled as twin epidemic because almost 43% of the diabetic patients also has hypertension. So coming to the prevalence of diabetes in India, an estimated 77 million Indian adults above the age of 18 years live with type 2 diabetes. And additional 25 million people are in pre-diabetic range. So overall almost 10 crore Indian population above the age of 18 years are living with type 2 diabetes. And in that, almost 50% of the Indian with diabetes are unaware of their condition. So almost 1 in every 5 adults above the age of 30, they are having diabetes. So why it is so prevalent in India and as well, why it is so prevalent in this generation? That is because of obesity and overweight, because increased abdominal and visceral fat increases the risk of insulin resistance, and also physical inactivity. So a sedentary lifestyle also increases the risk of type 2 diabetes, and unhealthy diet. So take a high intake of refined sugars, processed foods, and saturated fats, so predisposes the patient to develop type 2 diabetes. And some genetic and family history is also important. So coming to the definition, so type 2 diabetes is a heterogeneous group of disorders characterized by variable degree of insulin resistance, impaired insulin secretion, and increased hepatic glucose production, in turn which leads to hyperglycemia. So pathophysiology with respect to type 2 diabetes, the primary defect is insulin resistance. So the peripheral tissues like muscle, fat, and liver will not respond to the insulin. So the insulin dependent glucose uptake by these tissues, muscles, fat, and liver will be affected, that which in turn leads to high glucose levels, so high plasma glucose. So initially there will be compensatory hyperinsulinemia that occurs initially because our body or our tissues are not responding to insulin. So this initial stage there will be compensatory hyperinsulinemia, but over a period of time, finally the beta cell dysfunction happens. So that leads to insufficient insulin secretion in the later stages of type 2 diabetes. Coming to the symptoms, so patients with type 2 diabetes, because of hyperglycemia, they will have polyuria. This is because of osmotic diuresis, and polydipsia because of dehydration. Then weight loss. So weight loss occurs in patients with long-standing uncontrolled type 2 diabetes. So in the stage of insulin deficiency, in the early stage they will not have weight loss, but in the end stage, when they develop insulin deficiency, they will develop weight loss. And fatigue, weakness, blurring of vision. This may be because of retinopathy, and also this is due to reduced water content in the lens, that is because of dehydration. So and some frequent superficial infections, and also slow healing of skin lesions after minor trauma. So coming to the diagnosis, so a fasting plasma glucose level of more than 126 and random blood plasma glucose level of 200 and a HbA1c of more than 6.5 and 2 hour postprandial plasma glucose level of 200. So this is the cutoff to diagnose type 2 diabetes. So as I told, the prevalence of type 2 diabetes before, and as well as the almost like a 50% of the diabetic patients, they are unaware of diabetes. And also around 22 million population are in pre-diabetes stage. So it is very important to screen the patients. So what is the criteria for selecting the patients for screening? So the guideline says you should consider testing in any overweight or obese individuals who have any of the following factors. So if the patient is overweight or obese, and if he is having any family history of diabetes, a parent or a sibling with type 2 diabetes, he should be screened. And hypertension, any patient with obese patient who is having also hypertension, and also if their HDL cholesterol is less than 35 and triglyceride level more than 250, and any patient with polycystic ovary syndrome or acanthosis nigricans, or if the patient is already having any history of cardiovascular disease, so he should be screened. And the patient, any people with sedentary lifestyle, physical inactivity, so they are at high risk of developing type 2 diabetes, so they should be screened for type 2 diabetes. And any patients, any individuals with previous history of impaired glucose tolerance or impaired fasting glucose or HbA1c between 5.7 to 6.4, these people are labeled as pre-diabetics. So these people should be screened annually to diagnose type 2 diabetes, type 2 diabetes early and treat. So any woman who had gestational diabetes should be screened at least every 3 years. So around 10 to 15% of the women with the history of gestational diabetes, they are at high risk of developing type 2 diabetes in the future. So they should be screened at least every 3 years. So for other individuals, initiate testing at the age of 40 years and then repeat every 3 years. And any individuals with HIV also should be screened for diabetes. So in an OPD setting, so early diagnosis, early screening and diagnosis of type 2 diabetes is very important, because by the time that the patient is diagnosed to have type 2 diabetes, most of the patients might have already developed microvascular and macrovascular complications of diabetes. So it's very, very important to screen them early and start treatment. So coming to the management, the first and foremost important management part is lifestyle modifications. So with respect to lifestyle modification, the first thing is diet. So the recommended diet is whole unprocessed food like vegetables, fruits, whole grains, lean proteins and healthy fats. And physical activity, as like I told, sedentary lifestyle and also overweight predisposes the patient for type 2 diabetes. So they should aim for at least 150 minutes of moderate intensity or 75 minutes of vigorous intensity aerobic exercises per week. And weight management, so weight management can be done just with diet and exercise. So if it is not happening with just diet and exercise, now there are some recommended drugs like GLP-1 receptor agonists, so we can use the drugs. So, but initially they should be tried with diet and exercise. Then stress management with yoga and meditations, so that should be advised. So initially any patient who is diagnosed to have, according to the, so once the patient is diagnosed to have type 2 diabetes, first we should, like I told, should be screened for microvascular or macrovascular complications, because we don't know how long he has been diabetic before diagnosis. After that, we should look whether the patient has any acute hyperglycemic complications, so like diabetic ketosis or hyperosmolar coma. So whether the patient is acidotic, like does the patient have any breathing difficulty, or is severely dehydrated or looking sick. So we should first look for acute hyperglycemic complication. So if he doesn't have any acute hyperglycemic complication, then we can start treating him in outpatient, on an outpatient basis, first with the diet and lifestyle modification, then with the pharmacotherapy. So there are so many drugs. So but with respect to type 2 diabetes, the recommendations is to start metformin unless there is no contraindication. So the metformin should be the first drug to be started in the patient with type 2 diabetes on an outpatient basis. So you should give a maximum dose of up to 2.5 grams, and then with lifestyle modification, so for at least 2 to 3 months. So even with this treatment, if the patient's glycemic control has not reached, so the glycemic target, the recommended target is to have HbA1c of less than 7 and fasting blood glucose of 80 to 130 milligram per deciliter and a postprandial sugar less than 180. So this should be our target, and with less, like the patient should not have hypoglycemic episodes, frequent hypoglycemic episode. We should try to prevent that. So with diet and lifestyle modification and metformin, even after 3 months, maximum tolerated dose of metformin, if the glycemic control target has not reached, then we should select the second and third group of drugs, combination drugs. So that drug selection should depend on the patient comorbidities. So in a patient who is obese, so we should use oral hypoglycemic agents who also has some effect on the weight loss. So the drugs which who has very high efficacy in weight management are GLP-1 receptor agonists like semaglutide and tirzepatide, and also SGLT2 inhibitors, and weight neutral or metformin and DPP-4 inhibitors. And oral hypoglycemic agents with high efficacy in glucose lowering is GLP-1 receptor agonist, insulin, and SGLT2 inhibitors, and intermediate efficacy is DPP-4 inhibitors. So after metformin and lifestyle modification, the second choice of drug, if the patient is obese, we should preferably use GLP-1 receptor agonist based on the recommendation, and SGLT2 inhibitors, either of these two. If the patient already has any cardiovascular disease, atherosclerotic cardiovascular disease, or if he is at risk of developing atherosclerotic cardiovascular disease, so then they should be started with GLP-1 receptor agonist or SGLT2 inhibitor as the second choice drug, either of these two. And if the patient already has heart failure, after metformin, the second choice should be SGLT2 inhibitors because it has some anti-heart failure benefit. It is one of the anti-heart failure medications. So it should be the second choice. So if the patient has already chronic kidney disease, then we should use GLP-1 receptor agonist, which is proven CKD benefit, and SGLT2 inhibitors. So almost in all the group of patients, based on the recommendation, the second or the third choice of drug should be GLP-1 receptor agonist and SGLT2 inhibitors. Because GLP-1 receptor agonists are expensive, as an alternative, we can use DPP-4 inhibitors, gliptins, sitagliptin, vildagliptin and all, as an alternative. But the recommendation says we should use GLP-1 receptor agonist. So after lifestyle modification, metformin and the second drug, either GLP-1 receptor agonist and SGLT2 inhibitors, even after all these things, at the end of 3 months, if their glycemic control is not under control, then the third choice of drug should be used. Like I told, if we have used GLP-1 receptor agonist, we can use SGLT2 inhibitors. So with 3 oral hypoglycemic agents and lifestyle modification, if the glycemic control target is not reached, then we should start insulin. So I will just tell briefly about the insulin therapy. So the first, we should start always with the basal insulin when we want to start insulin. So it should be started at a dose of 10 units or 0.1 to 0.0 units per kg per day at bedtime. So this should be titrated every 3 days. Every 3 days it should be titrated at a rate of 2 units to reach the target fasting blood glucose. So even with this fasting blood glucose is corrected and their HbA1c is not meeting the target, then we should start prandial insulin. So it should be given before every meal. So it should be started 4 units. Then it should be titrated every 3 days by 2 units. So there are so many regimens. And also there are so many pre-mixed insulins. So with respect to insulin therapy, first we should always give oral hypoglycemic agents of 3 different classes. In that, at least one should be GLP-1 receptor agonist and lifestyle modification. Then we should start insulin. The first insulin should be started is basal insulin. Then we should go for prandial insulin. So, and what are the indication for insulin therapy, earlier insulin therapy? So at the time of diagnosis itself, if the patient HbA1c is more than 8.5 or if they are having any acute hyperglycemic symptoms, then insulin should be started at the time of diagnosis itself. So or else we can treat them on OPD basis with all the OHS and lifestyle modification. So monitoring, so patient should be advised about regarding the self-monitoring using glucometer and HbA1c. It should be done every 2 to 3 months. This reflects the glycemic controls in the last 2 to 3 months. And now the recommendation is to use continuous glucose monitoring because now HbA1c is not recommended because of so many shortcomings, false positivity and all. So the recommendation is to use continuous glucose monitoring. So this machine measures our interstitial fluid glucose every 15 minutes, so almost for 7 to 14 days, and it will give us a graph, 24 hours glucose graph. Based on that, we can see the fluctuations and also the overall glycemic control. So using CGM, there is something called total interval, the patient, the total time spent in target. So they will give the percentage over a period of 24 hours or over a period of 14 days, the patient has spent around 70% of the time in the target range. So that is more important than fluctuations like 1 or 2 hours of hyperglycemic period. So that is the gold standard now, but because of the cost we cannot use, but still we will be using HbA1c. And regular monitoring for micro and macrovascular complications should be done annually. Okay, thank you.
Intermittent fasting can help. How does it help?
Intermittent fasting, because intermittent fasting helps because of it reduces our glucose spikes. And also, is there any idea?
It will help if the quantity of if it will definitely help, one by reducing the spikes, two if the quantity of carbohydrate intake is less in intermittent. The basic philosophy is carbohydrate intake should be less. All your calorie containing things should be less. More so calorie dense foods. Calorie dense foods are equated to almost like smoking. That big a risk.
Thank you.
Thank you, Dr. Naveen. All the clinical sessions that we witnessed today, there's been one common thread, and that is the need for health education. Right? How do you effectively message all of this information? All these technicalities is really for our understanding. But how do you simplify it and tell every single patient is what is the last topic for the day. I invite Dr. Nandish from the Department of General Medicine to talk about health education using health spoken tutorials.
Sairam, everyone. I'm aware it's the last session and I've been given 5 minutes. So I want you to remember only 2 keywords. One is this booklet's name, MIYCN booklet. The other thing is health spoken tutorial. Health spoken tutorial is the name of a YouTube channel which has almost 100 odd videos on nutrition starting from pre-pregnancy to elderly care. And health spoken tutorial, this is the logo of it. It is a project by IIT Bombay through whom we have got all these materials. All the videos have content on what a pregnant woman should eat, what a lactating woman should eat, breastfeeding skills. Breastfeeding skills, there are 45 different points. All these are available in this book. I will be going through them. So all these topics are validated or they have been tested in various states. Currently there are projects going on in Madhya Pradesh, Chhattisgarh, Maharashtra, shortly in Meghalaya, West Bengal, Jharkhand. All these places, these have been tested. The knowledge is clearly understandable to a layman also. So there is a special course on NPTEL by the main project lead, Dr. Rupal Dalal, who works in IIT Bombay also. I will just go through this booklet. This booklet we are using in our hospital for antenatal counseling, which you would have seen or have heard of. Similarly, the content in this book will be taught to every postnatal mother who has delivered a child regarding how breastfeeding can be, the focus can be shifted from exclusive breastfeeding to effective breastfeeding, so that child grow in the right way as per WHO growth standards. After that, we also have content on complementary feeding, the food which is started after 6 months of age. Detailed guidelines are there. My wife is a pediatrician here and studied in one of the best government colleges of Karnataka. She tells, no one taught us about breastfeeding and complementary feeding the way this book or the videos which are there in YouTube teaches us. So apart from this, we also have few videos on each micronutrient. Like if someone is iron deficient, you can share them 3 videos. One is importance of iron to all the age group. One video is there. It is available. All the videos are available in around 10 odd major languages. Currently, there are translations going on into tribal languages of Garo, Khasi, Jaintia, Santali. All these languages they are trying to translate. There are even Spanish, Arabic languages also set of videos. So because of technical reasons, I couldn't show you the YouTube page. But if you go to the YouTube page and subscribe to Health Spoken Tutorial, you will get 100 odd videos, starting from what is carbohydrate, protein, fat, what are the foods which are rich in good fats, what are the foods which are rich in iron. And they also have recipe videos for iron-rich recipes for vegetarians, iron-rich recipe for non-vegetarians. Similarly for folate, B12, vitamin C, calcium, magnesium, many micronutrient related videos are there. And like in the previous session, there was a mention of word called insulin resistance. What does insulin resistance really mean? They have good animated videos explaining to a layman, they are that simple topics. So make use of that video. Here we also share in the antenatal period itself few set of videos to pregnant mothers. Kindly have a look at this video so that you will be ready to understand how to hold a baby, how to get a good latch. And they also have recipes videos for even complementary feeds, like how you have to prepare ragi millet based recipes for children, or even how to include paneer or nuts and seeds, vegetables, all from starting from what foods to select to how to cook, everything is covered in this set of videos. So could you please go to the book? Okay, so in this booklet, the flow is initially we have nutrient-rich food groups, like protein-rich vegetarian sources. Next is non-vegetarian sources. Next, can you please go further? Next we have omega-3 fatty acids, which we talk on fats. Next, iron, folate, B12, vitamin C, calcium, magnesium. Move a little fast. Next. Come down. Come to the diet plan for pregnant women and lactating women. So we also have a detailed plan for pregnant women and lactating women, for a vegetarian who consumes milk, a vegetarian who consumes egg, and a non-vegetarian also. 3 recipes, 3 plans for pregnant women, 3 plans for lactating women also. Further down. Next. Okay, from here on, a detailed content is there on breastfeeding. Move a little fast here. So what all things are covered here in the previous last 10 slides is what is the size of baby's tummy, how much we should feed, how often you should feed, and how you have to store the expressed milk, how you have to express. There is a technique to express to get a good amount of milk when you press it. All that are there. From here on, there are 45 detailed points on how mother should get prepared, how baby should be prepared to breastfeed, and how to check whether this side milk is emptied or not. All such queries can be answered through these 45 points. Go to the last. So here comes, this is the dietary diversity group. So any kid who is more than 6 months should have a minimum of 5 food groups out of these 8. This is a WHO dietary diversity cutoffs. So any 5 groups must be included. So all these things are available in video also. Move further. So go back. So here we have how much cups of food should be given at 6 months, 6.5, 7 months, 8 months, 9 months, at 1 year. How much quantity, how frequent, what consistency, and how to introduce new foods. All guidelines are available in videos and this material. Go further. These are sort of follow-up activities and all. And we have growth charts here and this ends. So any of you are interested to access all of the videos at once, you can scan that YouTube videos over there. If you want to download this material, you can download from this QR code. NPTEL MIYCN videos are the list of videos where Rupal ma'am explains herself each of these components for a NPTEL course. Anyone can join that course. The registration starts in November of month and the course actually starts in January. It's an online course with weekly videos. You can give an exam. If it's up to your choice, it is freely available. Only thing is you have to pay 1,000 rupees if you want to appear for NPTEL exam. That's online also. And TD640 is a playlist where Rupal ma'am, this is the playlist which is taught to IIT Bombay engineering students about nutrition by Rupal ma'am. Ma'am has experience in remission and reversal of diabetes, hypertension, PCOS, all other major non-communicable diseases. She explains detailedly. This may be limited to people who have a good amount of or minimal understanding of English because that's available only in English. Finally, they have a website. You can access there this material or any additional things which you want to. So we have been using this for the past 2-3 years. Many myself, my colleague Panindra sir, Abhishek sir, all of us had our own kids, and we are relying on the YouTube videos which Rupal ma'am has developed, and our children are going relatively better in good percentiles currently. Yes, so the most important thing is I studied 10 years in Bangalore Medical College. That's the top government medical college in Karnataka. No one taught us what is there in this book actually. If I ask any other medical college students, they will tell which are the iron-rich food, they tell jaggery. What the reality is, turmeric has the highest iron content, that too at par with whatever non-veg foods which are high. And many other misconceptions can be broken by understanding these videos because all of these are based on NIN recommended document called as Indian Food Composition Table. So no question on it is a vague or wrong information. All these are government document related contents, and all these videos are Ministry of Human Resource Development approved videos. So this is a very big tool to be used in the community setting. Kindly make use of this. That's it from my end. Thank you.
What a lovely end to the clinical sessions. Very practical. Of course, we'll make sure that this content is available. Videos are already available online. Thank you all. Thank you for sitting through all the clinical sessions. This marks the end of session 1. The evening program will be at 5 p.m. in Premamritam in the Divine Presence. So we'd request all the delegates to kindly be present in Premamritam by 4:30. Be seated there by 4:30. We'd now request the doctors, senior members of all the teams to kindly move in for lunch at multipurpose hall. We have a 5-minute interaction with the volunteers, post which we will disperse completely. So I'll request all the doctors and senior members to kindly proceed for lunch. Brother Sanjay will help you downstairs to board onto the bus. I request Shubhajit and Venu to